Hemant sir, good evening, sir.
Good evening, sir. Good evening.
Rajiv sir, good evening, and other senior faculty who are just joining.
Good evening,
sir.
Good evening, everyone.
Good evening, sir. So it's 8 o'clock. We will start as the faculty keep joining. We'll start the session. We have two important cases for the day. One is obstructive jaundice to be presented by Dr. Manish, kindly contributed by Professor Amit Gupta sir from the All India Institute, Rishikesh. The other case is multinodular goiter, kindly contributed by Dr. Guru Shantappa Elagachin, Professor and Head of the Department of the KIMS Hubli. And the case is going to be presented by Dr. Ramachandra. And I also warmly welcome the other senior faculty. I could see Dr. Robin, I could see Dr. Rajesh and others joining. So I think I'm sure most of the faculty have already been here. So you can right away start the discussions. We have 1 hour for each case because today we have two long cases. So take it that way. First half an hour we will limit to clinical discussion. The second half an hour you take up to the evaluation and the management part of it and a little bit. Then we allocate 2 minutes time for the candidates to clear any doubts if you have on the side. So with that, without much ado, I'll call Dr. Manish to introduce himself. Here he's unit chief and head of the department and start his presentation. Good luck to you, Dr. Manish. Over to you.
Thank you, sir. Is my screen visible?
Yes, good to go. I request non-participants and non-faculty to keep kindly muted. Faculty and presenting students alone can be in unmuted mode. Please be mindful. Thank you. Good luck to you, Dr. Manish. All the best.
Thank you, sir. I'm Dr. Manish, third year PG from General Surgery Department of AIMS Rishikesh. My moderator is Professor Amit Gupta, a professor of Department of Surgery, AIMS Rishikesh. Today's case is Mr. X, a gentleman aged 68 years, a resident of Garhwal, Uttarakhand, a retired accountant, presenting with chief complaints of yellowish discoloration of eyes for the last 1 month, passage of high-colored urine for the last 1 month, and itching over the chest and trunk for the last 15 days, and passage of black tarry stool 10 days back. A patient was apparently well 1 month back when he developed yellowish discoloration of eyes for the last 1 month, which was noticed by his family members, which was painless and progressively increasing, but only for 1 month, and yellowish discoloration of urine for the last 1 month, and associated with passage of clay-colored stools with an episode of black tarry sticky foul-smelling stool 10 days back. There was generalized itching over the trunk and chest for the past 15 days, which disturbed his sleep. And there was history of loss of appetite for the last 1 month with unintentional weight loss, which was elicited by loosening of clothes. Continuing the history of present illness, there was no history of any prodromal features like fever, malaise, jaundice, joint pain before onset of the yellow discoloration. There was no history of any sharing of needles for IV drug abuse or tattooing or blood transfusions in the past. No history of pain abdomen, vomiting, or abdominal distension. There was no history of any fevers with chills, palpitations, or decrease in the urine output or altered sensorium. And there was no history of any altered bowel habits or fresh blood in stool. There was no associated history of any headache, seizures, shortness of breath, cough, hemoptysis, backache, or bone pain. Going to the past history, a patient had a history of postprandial pain in the right upper quadrant of the abdomen on and off 6 years back, which was evaluated outside and treated with laparoscopic cholecystectomy 5 years back. And a histopathology report was available, which showed chronic cholecystitis. And this was done outside at Nirmal Ashram Hospital in Rishikesh. But no documentation of the treatment was available. But from the history elicited, there was no drain placed in the post-operative period. There was no pain, jaundice, or fever in the post-operative period, and no other symptoms in the past 5 years. There's no history of any other abdominal surgeries or treatment. There was no history of any TB, hypertension, type 2 diabetes, asthma, and or thyroid disease. No history of previous jaundice. No history of any other chronic drug intake or any allergy note till date. Moving on to the personal history, he is married with 3 children. He takes a vegetarian diet. There are no addictions, and sleep is disturbed due to generalized itching, but he's having a normal bowel and bladder habit. Family history, there's no history of similar disease in the family members or neighbors, and no history of any malignancy or malignancy related deaths in the family. I would like to summarize my history here. A gentleman aged 68. Pardon, sir?
No, go on, go on. I think this is
A gentleman aged 68 years presented with painless progressive jaundice for 1 month, associated with high colored urine, generalized itching, passage of clay colored stools, with one episode of black tarry stool 10 days back, with loss of appetite and unintentional weight loss, with no prodromal symptoms, with a history of laparoscopic cholecystectomy for chronic cholecystitis 5 years back.
So what's your professional? Manish?
Sir, going by the history, my provisional, going by the history, my provisional diagnosis is obstructive jaundice secondary to periampullary carcinoma, and I have kept some DDs also in the order of head of pancreas, followed by distal cholangiocarcinoma, followed by duodenal carcinoma.
Okay, let's go to your first slide. That's fine. Okay. So jaundice and high colored stool and itching and then black tarnish. Okay, next slide, please. So there was clay colored stool followed by melena.
Yes, sir.
Right. Okay. So why is this urine dark and the stool clay colored in obstructive jaundice?
In obstructive jaundice, since there is obstruction to the passage of bilirubin uh, to the intestines, which gives the yellow discoloration to the stools. So that's why the color of the stool becomes clay in color, and there is a reflux of the absorption of the direct bilirubin and into the bloodstream that causes, which is excreted by the renal system, because the direct bilirubin is water soluble, and thus urine is high colored.
So what makes the urine? What is that content, that chemical which makes the urine dark?
Urobilinogen.
Urobilinogen. Where is urobilinogen formed?
Urobilinogen is it is formed in the intestine. Direct bilirubin is the
Yes, it is bilirubin.
yes, direct bilirubin only. Yes, sir.
Right, which is water soluble. Okay, next slide, please. Prodromal features. What do you take for that? History for that?
To rule out any history of hepatitis, sir, or medical jaundice, sir.
Okay. Pain, abdomen, vomiting, and abdominal distension. How can you relate this to obstructive jaundice or periampullary carcinoma, which is a differential?
For pain abdomen, because obstructive jaundice can be differentiated into painful and painless, so it will help me diagnose the case. because certain cases have pain, certain don't, and vomiting and can be
No,
a
no, no. Let's finish off with the pain. What are the causes of obstructive jaundice with which is a malignant obstructive surgical jaundice, right? Which is uh, painful.
gallbladder carcinoma, sir, and hilar cholangiocarcinomas.
They are painful, are they?
Yes, sir.
Is it?
Yes, sir. Gallbladder carcinoma.
Why should a gallbladder carcinoma be painful? This patient has lost his gallbladder. Yeah? It's been removed.
Yes, sir. In this case, we won't have
So why are
gallbladder
you thinking of gallbladder? Right?
as a DD, sir. In hilar cholangio, we can have painful jaundice.
Hilar cholangio. Why should hilar cholangiocarcinomas be painful?
Because of the biliary obstruction, cholestasis that causes increase in the ductal pressure and colic pain. Even distal cholangio can have pain.
So all obstructive jaundice, by your logic, all obstructive jaundice should be painful. They all will lead to dilated IHBR.
I'm not sure.
So it is usually see a head of pancreas, right? And sometimes because of distension of the Gleason's capsule, because of edema of the liver, that can cause some pain, right? What about vomiting? What kind of periampullary carcinoma can cause vomiting?
CA head of pancreas, when it causes infiltration of the duodenum or the stomach, can cause gastric outlet obstruction. That can cause vomiting.
Anything else? Because by absence of these symptoms, you can rule out certain types of periampullary, can't you?
Duodenal carcinomas also, they can cause obstruction.
Okay. Okay, chills, rigors. Okay, okay. What about melena or hematochezia? What periampullary carcinoma will usually have this kind of feature?
Again, sir, the head of pancreas, if it infiltrates, most common is periampullary carcinomas or some variants of papillary distal
Periampullary
cholangiocarcinomas.
is most commonly results in melena, does it?
No, sir. I mean, that is one of the in periampullary carcinoma we can see sloughing of a tumor that can cause melena. Even head of pancreas, when it infiltrates into the duodenum.
No. Dr. Manish, you're not understanding the question. Periampullary carcinoma does not present usually with the melena. Which among these of the four constituents from which one is classically presentation as melena?
Duodenal carcinoma.
Better than that, ampullary carcinoma.
Ampullary
Because the thing you were explaining that the tumor sloughs. So that is the characteristic of the ampullary carcinoma. So classically, it presents with that. That okay. Right, continue.
Next slide. Okay, this is objective. Don't write all this. How does getting his surgery done at Nirmal Ashram Hospital come help you in diagnosis? It doesn't. Right? It's not done. Yeah, you just say that he underwent lap cholecystectomy 5 years back with you. All this thing is not required.
Yeah.
Right.
And you have taken a history of no post-operative drain, pain, jaundice, or fever. What is the importance of taking this history in a case of cholecystectomy?
So I wanted to rule out if there was any bile duct injury.
Bile duct injury. Good. So, what is the usual time by which the CBD stricture? You mean to say now that's the CBD stricture, right?
Yes.
That could present as obstructive jaundice. So, what is the usual time of the presentation of?
Stricture usually takes 4 to 6 weeks to form, but there can be varied presentations, sir. Mostly it can also present after years after the surgery, where it can present as recurrent cholangitis. And
usually, how much time? Usually, 6-7 years is not the usual presentation if there is a bile duct injury at that time. 6 years
months.
back. 6 months to 2 years. Usually, within this period, the minor bile duct injuries will present as a obstructive jaundice due to stricture, biliary stricture, right?
Yes.
Okay. So you want
Dr.
to
Manish,
ask? Yeah.
Sir, please.
Dr. Manish,
Yes.
am I audible? Yes.
Yes.
Okay, fine. Now, what gives the stool the normal color?
Stercobilinogen, sir.
Is it stercobilinogen or stercobilin? Okay,
Sorry, stercobilin. Sir.
okay, whatever. So, what is the importance? Is there is the importance of the colonic intestinal flora in giving the normal color for the stools, right? So, okay, carry on, continue.
Yeah, Manish, can there be jaundice without dark colored urine?
In acholoric jaundice, specifically, which is seen in prehepatic jaundice, like hemolytic jaundices, we can have
Hemolytic.
normal color urine, sir.
Why it happens?
Because indirect bilirubin is albumin bound and it does not get secreted in the urine.
Okay. And the chronic drug intake you said.
There are some drugs that can cause intrahepatic cholestasis, like erythromycin, amoxiclav, or steroid use.
No. So do you think amoxiclav, erythromycin, somebody will take for long duration? These are the antibiotics and only 5 to 7 days
allopurinol,
course.
there are some other drugs, probenecid and sulfonamides.
Yeah, you have already asked for the history of seizures.
Yeah.
So, anti-epileptic drugs.
Anti-epileptic.
Yeah,
Phenytoin, yes.
phenytoin. Phenytoin. Yes, yes.
And the tuberculosis, tuberculosis,
Yes,
because the
tuberculosis.
patient may be
Rifampicin.
taking ATT, that, right? So there is no history of tuberculosis, so that is also already ruled out. Okay. Please go to the next slide.
1 second.
Yeah,
Dr.
please.
Manish, what other condition can cause yellowish discoloration of skin sclera? I mean, the skin and mucous membranes. What other condition other than jaundice?
Hypercarotinemia can be there.
Yeah, carotenemia. Yes. So, how do you differentiate carotenemia from jaundice clinically? Is there a method?
It does not
Carotenemia
stain the
usually spares the sclera.
Yes.
No, that. Yes. Why is jaundice manifested in the sclera in case of jaundice itself?
Direct bilirubin has a affinity towards elastin, which is present in the sclera. So
It is abundant in sclera. Right. Okay. So in presence of anemia, where do you look for jaundice? If at all it is possible, which are the sites for you to look at?
Jaundice is not only seen in the sclera, but we also see them in the nail beds and the dorsum of the tongue and palms and soles. So we can look for them in these regions.
Okay.
Manish.
Yes, sir.
What is aerobilinogen? How it is formed?
It is formed in the when the bilirubin reaches the intestine.
What is bilirubin metabolism? This is very important question for PG exam. Integrated physiology.
First, there is hemoglobin degradation from RBCs, hemolysis.
Okay.
Then heme is released and globulin is reabsorbed to the protein pool, and the heme goes to the reticulo endothelial tissues, where it gets metabolized to via heme oxygenase to indirect bilirubin, unconjugated bilirubin, that gets bound with albumin and goes to the liver, to the hepatocytes. And in the hepatocytes, it gets absorbed, and then it undergoes glucuronization in which it converts into direct bilirubin. Then this direct bilirubin, with the help of active pumps, is secreted into the biliary tract that goes to the enteric system via the biliary system. After it reaches the biliary system, it gets converted into urobilinogen and further into stercobilinogen by the bacterial action. This urobilinogen gets absorbed sometimes into the blood, and some amount is released in the urine also. And the stercobilinogen converts to stercobilin and gives the yellow color to the stools.
Then what is enterohepatic circulation?
Enterohepatic circulation is in relation to bile salts, because they are products of cholesterol metabolism in the livers that is produced in limited amount, and that is when it gets it helps in micellary formation and conversion fat absorption. So it is necessary, and it has to
Reabsorption
be
of the bile
recycled
salt from the terminal ileum
from the terminal ileum, and then so that
and
the
return
pool
back to the liver
releases.
up to 95%.
Pardon, sir, I could
continue.
not hear the question.
Okay, continue.
Should I
Okay,
go
go
out?
ahead. Go ahead.
Hello, Manish. Hello,
Okay.
Manish.
Yes, sir.
Yes.
In the previous slide, you asked, please go to the year. You asked the history of jaundice. No previous history of jaundice. Why?
So I wanted to rule out if the patient has had recurrent jaundice in the past, like primary sclerosing cholangitis or primary biliary cholangitis, cirrhosis can have such symptoms. Also, CLD can be. I wanted to rule out if patient had jaundice in the past. Also,
So, what is the
No.
commonest cause of recurrent jaundice? What we call it waxing and waning jaundice.
biliary strictures can be one.
No.
And,
It's not waxing. Why they will be waxing, waning in biliary structure?
Hmm.
Why the jaundice will disappear?
Okay. Ampullary carcinomas and
Yes. Papillary
can
carcinoma and
cause vaccine waning because of sloughing off. So
sloughing of the
Yes.
ampullary
Any
and the
other cause?
ampullary carcinoma. And sometimes in
there can be rare causes are there that duodenal diverticula can be there causing Lebel syndrome. That can
More
cause
commoner cause.
cholelithiasis can cause intermittent jaundice, in which if the stone is passed, it can cause.
So can
That is the
this
name of
can you
fire.
consider this as your among your differential diagnosis in this case?
Because a patient is currently painless, so
Painless. One point
painful
is
jaundice would be related with cholelithiasis.
usually it is painful. And what type of jaundice? If the patient had the pain, then can you think of that?
Sorry, sir, I didn't get the question.
If the same history and the patient also had the complaint of pain.
Still, I would looking into the age of the patient and the loss of weight and appetite which is associated with it, and also a history of melena, I would go for a malignant cause, which can be
No,
either
do you think melena can only be due to the sloughing of the tumor, or there can be other cause of the melena in a case of obstructive jaundice?
other causes can also be there, sir,
Like?
direct infiltration of the tumor, or
Apart from that,
concurrent portal hypertension can be there that can cause bleeding varices, or sometimes in such sick patients we can have stress ulcers.
simple gastritis can cause bleeding in this
gastritis.
patient. No, deranged INR can patient with obstructive jaundice. So deranged liver function simply can lead to increased propensity for bleeding, right? So regarding the stone, could it be possibly a stone?
Sorry, sir. Could you please repeat the question?
Yeah, like after cholecystectomy, when do you call it a slipped stone causing a jaundice, or when do you call that the stone is primarily formed in the CBD after cholecystectomy?
There are other retained stones or recurrent stones.
Yes.
Within 2 years, it's retained stones, and after 2 years, it is recurrent stones.
It is, you know, so sometimes it could be the small slip stone at that time which has increased in size, and that can cause a episode like this jaundice. But usually they are painful jaundice. It's right.
Okay, in
Yeah,
a case
Dr.
like
Manish.
yours, what other color abnormality can you come across in the stool? Any other color? Black tarry stools you mentioned. That is okay. Any have you heard of aluminum paint color stool?
Yes, when in cases of pale colored stool, melena gets mixed with it and causes aluminum colored stools or Thomas sign, which may be present. But in this case, the patient had black tarry stool only,
Okay,
not
okay,
illicit.
okay. Fair enough. Fair enough. Can you proceed?
Dr. Manish, what about diabetes? How is it related to CA to periampullary carcinomas?
Could you repeat the first part of the question?
Dr. Mallikarjun, I think you need to use, sir. Yeah. Dr. Manish, how is diabetes related to your case? Is there a relationship between diabetes and periampullary carcinomas?
So, in the risk factors, no relation as such has been found, but obesity and diabetes and metabolic syndrome have been there. So, but
No,
no.
any other way? Is it intimately related to this?
Yes, yes. In patients of in such patients, we can have a type 3C type of diabetes because of the uh, chronic pancreatitis. The patient has a predisposing chronic pancreatitis.
No. Dr. Manish, usually, sometimes recent onset of diabetes in a patient of any tumor in the pancreas is a sign for pancreatic carcinoma, and diabetes can precede CA pancreas by almost 2 years. So if he's had a history of diabetes about 2 years back and suddenly develops this, it's a pointer towards, also aversion to smoking. No, that precedes obstructive jaundice. Sir, please.
Can we proceed to the next slide? Okay, next slide, please.
No, if he's had melena, will his bowel habit be normal?
No. Yes.
Yes, I had already meant I should have mentioned against melena and pale colored stools.
Yeah. Okay. Next slide. He's got no symptoms of LUTS, bladder outlet obstruction at 68.
He didn't complain of any such in history.
No, did you ask for it specifically? Because at 68, come on, some sort of thing happens. Not because of has anything to do with your diagnosis, but post-operatively, you may have some problems. So you got to just find out, at least after 60, that whether they were.
Sorry.
What malignancies are you looking for in the family?
Sir, we are looking for hepatobiliary malignancies or
anything more common? Is BRCA related to this?
breast malignancies or ovarian malignancies.
Ovarian, not in a male. In this, what are you looking for?
Family.
Because those questions are missing in your history. That's why I'm asking you. You've not taken any history for bladder problems. You've just written it's not. I would like to have a more specific thing, right? Because CA prostate is there. Any swelling, any other swellings in the body, CA breast, in male breast, all this has to come up, okay? Right. So, next slide. Okay, should we move to the examinations?
Manish, one question, like you asked the family history with a similar complaint, huh? But
Yes.
what percentage of periampullary carcinomas, especially ductal carcinomas, have a familial inheritance due to germline mutations.
I'm not sure.
It's roughly 10% patients. So, so this history is important. Whether there is a history of similar jaundice, obstructive jaundice, and history of periampullary carcinomas in the family. Okay.
What is the relation of BRCA2 in this, in terms of pancreatic cancer? It is associated with sporadic pancreatic cancers. Any other genes that, mutations that can lead to pancreatic cancers? Other genes?
There can be a KRAS and P53.
Yeah, very good, very good, very good. Okay, that incidence is there. All right.
Okay, examination, please, Manish.
Okay.
Coming to the general physical examination, the patient was alert, conscious, cooperative, oriented to time, place, and person. Febrile to touch with an axillary temperature of 98.6 degree Fahrenheit. Pulse rate of 76 beats per minute in the right radial artery with a regular rhythm, good volume, and no radial delay.
Look, hang on, Manish. Don't give us all this radial femoral. It's not a vascular condition. It's got nothing to do with it. Your Viva will go haywire if you do this. Someone's gonna ask you about all that. Don't dig your grave. Go on.
He had a blood pressure of 110 by 70 millimeter of Hg of mercury in supine position in the right brachial artery, respiratory rate of 18 cycles per minute, and a respiration and a oxygen saturation of 98% on room air. Patient icterus was present. Pallor was not present in the nail beds or dorsum of the tongue. No clubbing, no cyanosis, no edema. No peripheral lymphnopathy or left supraclavicular lymph node lymphadenopathy. The patient had normal build but was malnourished, well hydrated, tongue was moist. Weight was 42 kgs with a height of 165 centimeters with a BMI of 15.4 kgs per meter square. ECOG of 1 and a Karnofsky scale of 80. Neck veins were not visible. No lump was palpable in the neck, and scratch marks were present over the trunk, and no signs of chronic liver disease were there.
Okay. Well, what is the importance of that lymph node in this case, supraclavicular lymph node?
To look for any metastasis to the lymphatic metastasis to the.
So what is the sign description called?
Truger sign, which is and this is the Virchow.
It is a node.
Yes. Sir.
What is Virchow's? Virchow's node. Heard of Virchow's node?
Virchow's node, and if it is palpable, it is a Truger sign.
Yeah. Where else will you get a Trousseau's sign with respect to pancreas? Another Trousseau's sign.
Migratory thrombophlebitis.
Okay. What is Trousseau's sign? Trousseau's.
Carpopedal spasm in hypocalcemia.
Okay. Go ahead.
Dr. Manish, just go back. Yeah. Normal built and nutrition. No, go back. With a BMI 15.4.
Sir, I said malnutrition. It was a typing mistake. So
right. Not okay.
Yes.
Such a deeply jaundiced patient, I don't expect him to be well hydrated. I don't. They're usually dehydrated. Right. Okay.
Scratch marks are present. So, what is the basic cause of itching here? A basic question.
There are the actual cause is still not known, but previous theories were suggesting factors which were released by the liver itself, like bile salts or mast histamine release from the mast cells. But recent studies have shown central pathways get sensitized, which causes a
look. Liver doesn't secrete. Manish, liver doesn't secrete mast cells.
No, sir.
These bile salts activate mast cells,
causing mast cell activation and causing histamine release
in the dermis, and it irritates the free nerve endings. These are all hypotheses. But when you manage the case, you have to manage the itching part also. So you
Yes.
should know what is going behind the itching, that part of it. Okay, please carry on.
Coming to the abdominal examination, patient was examined in a supine position with adequate privacy in the presence of a chaperone, with adequate exposure from nipple to mid-thigh. On inspection, patient's abdomen appears scaphoid in shape. All quadrants move proportionately with respiration. Bilateral flanks appeared normal. Umbilicus was inverted and in the midline, and scratch marks were present. No dilated veins, sinuses, or fistulas were present. There was scar at the umbilicus, epigastrium, and right hypochondrium, and no visible lung peristalsis or pulsations were seen. At the hernia sites, there was no visible cuff impulse, and inspection of the back spine were unremarkable, and external genitalia appeared normal.
ಕಳಕುಡಿ ಬಸ್ ಬಂತ
Yes, sir.
ಬರ್ಬೇಕಲ್ಲ ಇನ್ನ
I'll continue. Going to the palpation. On superficial palpation, there was no local rise of temperature or tenderness. There was no lump palpable in the abdomen and no tenderness on deep palpation. Hepatomegaly was present with margin of liver palpable 5 centimeters from the right costal margin with a smooth surface and no nodularity and a rounded margin. The spleen was not palpable and no palpable cuff impulses at the hernia sites, no free fluid, no fluid thread, and no spinal deformity and paraspinal tendernesses, and there was no renal angle tenderness or fullness present.
Okay, no
Just
local rise of
Manish,
temperature.
please go back.
Please,
Yeah,
please.
please, sir.
No local rise of temperature. So which scenario you can expect an increase in temperature in this patient? That is one thing.
Inflammatory causes in this patient.
Yeah,
If
if
the
the
patient
patient is
has
in cholangitis also, he can develop
yes.
you know, fever, isn't it? The second thing is, you said there is a hepatomegaly. So what
Yeah.
could have been the cause for this?
And
cholangitis itself can
no,
cholestasis can cause
patient is not in cholangitis, no? Your patient is. And what
No,
is the
other than
upper
cholangitis.
margin of the liver? Can you
sir,
just
I've mentioned
comment
it in
by
the percussion.
yeah?
I've mentioned it in the percussion, sir.
How do you do the liver percussion? How do you do
Okay.
the liver percussion?
I will start by coming down the first identifying the sternal notch. Then from there I will come down and get the angle of Lewis. From there, laterally the rib which will be there will be the second rib. Below it will be the second rib space. I will count, start percussing from there in the midclavicular line, and come down. And where the dullness starts, I will point it as liver dullness, and from there we measure up to the costal margin, and if there is any other margin of the liver palpable, we'll add that to the liver span, and that will be our liver span in the midclavicular line.
Why do you start from above downwards? Like, is there any logic?
Coming from resonant to dull is easier to appreciate.
That is one thing. That is one aspect. The change of the character. Apart from that, liver enlargement can be upwards also.
Yes.
Enlargement of liver can go upwards also as well. So you have to get from that side. As you go lateral, as you go downwards, you have to go laterally also. What is the logic? Have you heard that?
Yes, sir. Because
why is it so? Slightly laterally you point as you
because of
come
the cardiac dullness.
That is one thing. But apart from that, because the left lobe slightly comes a few centimeters upwards. And what is the cause for hepatomegaly in this scenario?
It can be due to cholestasis causing edema and the liver.
Cholestasis.
Cholestasis, yeah, right.
What is hydrohepatosis? Heard of that word? Hydrohepatosis. In case of obstructive jaundice itself, it can happen. So due to the distal compression, regurgitation of bile, stasis in the liver, that can cause getting back to the sinusoids. Liver gets slightly enlarged. It will be soft. That is described as hydrohepatosis. Okay, please go ahead, sir.
Yeah, Dr. Manish,
Yes.
like whenever you make a comment on the hepatomegaly, you have to do the percussion simultaneously. Don't say that I will tell the upper border during the percussion, right?
Yes.
In the same examination, you have to percuss to get the what is the upper margin of the liver. One thing. Second, you have written no fluid thrill. When
Yes,
do you
sir.
get a fluid thrill?
When there is free fluid in the abdomen more than 1 liter. Sir.
No. You get it
No.
when you have a tense ascites, right?
Yes.
That is the shifting dullness which you
Oh,
get.
sorry. Yes.
Huh? So you should have better written it here. Non-distended abdomen is here, so there is no shifting dullness.
Yes.
This
Or
test
no
is
free fluid.
this test is invalid in this patient because the patient is having a scaphoid abdomen. There is no distension. So you cannot demonstrate the fluid thrill test in this case. You should have better written for the free fluid in the abdomen as a no shifting dullness present. Right? Okay. Please go to the next slide.
On percussion, the liver span was 15 centimeters in the midclavicular line. Percussion over the abdomen was tympanic, but no shifting dullness was present, and bilateral renal angles were resonant. On auscultation, bowel sounds were present and normal. No left supraclavicular lymphadenopathy was present.
Why renal angles are resonant?
Because of the small presence of small vowels in that normally.
Is it?
If it's not,
Where's the renal angle?
Yeah.
it is
It is
between
a-
the 12th strip and the
Where's
erectus
the renal
pili.
angle?
It
Where
is
is
in
the
the
renal
back, or it is in the back, or you palpate
Back
from the
in the
front.
back, sir.
So
So you
then
get resonant there because the bowel is lying there underneath the posterior
you mean
abdominal wall.
you mean to say it is bowel is behind the kidney there?
So the
I mean, why do you have to put this here? Look, Manish, what I'm trying to say, if you try to put too much information which is not required, then you'll end up with these kind of things. In an exam, don't try to impress your examiner, right? If you just stay your normal, present it normally, he'll be impressed. But if you try hard to impress, then you'll end up with these kind of things.
Yes.
Okay?
Right.
Yeah.
So there is no organomegaly, though there is no flank fullness. And then you are saying the renal angles are resonant. They cannot be resonant from behind. You are percussing it from behind. A renal angle you see there. So there is no bowel behind the kidney. How they can be resonant in that area, right? So omit this examination when you are presenting a case with the no organomegaly, no intra-abdominal lump, no flank fullness, right? Okay.
Okay. Are there any features of liver cell failure?
No, sir.
If so, what are they? What are the features of liver cell failure?
Liver cell failure can present as a Palmer erythema. There can be leukonychia. There can be Dupuytren's contracture, flapping tremors in case of if it is encephalopathy, and there can be a loss of axillary head. There can be xanthelasma, enlargement of the parotid glands. There can be spider nevi over the chest or back, and there can be
Okay. I think you know it all. Yeah. Okay. Yeah.
Okay,
Good.
fair enough. Okay.
Next slide.
But on per-rectal examination, the perianal skin was normal, no fissure, fistula, induration, or tenderness. On digital rectal examination, there was no mass, mucosa was freely mobile, no nodularity or free fluid in the pouch of Douglas. Single fecal stain was present, which was clay-colored in stool, and no blood stain was present. Other system
Manish, just a minute. Don't write per-rectal. You have written it's perianal examination, right? Then you have digital rectal examination. It's okay. So above the first line should be perianal examination, not per-rectal examination.
Yeah.
Okay.
1 second. In this case, if the spleen was palpable or enlarged, in such a scenario, what would you be thinking about?
If the spleen was
In a case of
palpable,
obstructive jaundice? Yeah.
I would think that the patient has concomitant portal hypertension also, which can be due to portal vein thrombosis or a splenic vein thrombosis.
Hang on. Now, where does this portal hypertension come in here? Just because the spleen is enlarged, you think of portal hypertension and splenic vein thrombosis. Are there any features of portal hypertension in this patient? And why should you think of portal hypertension here? What are the features of portal hypertension?
There can be a caput medusa. There will be splenomegaly
Splenomegaly, ascites, and bleeding of
varices.
varices. Yeah, nothing around
Vinay,
except for spleen.
Vinay, what are you trying to explain? Like in a case of obstructive jaundice, suspected case of periampullary or carcinoma of pancreas, suppose the spleen is enlarged, what would be the possibility? It can be either a compression, okay, due to the lymph node or the mass as such, the mass of pancreas that causing the obstructive jaundice. Or in later stages, it can be portal vein compression, splenic vein thrombosis. In such cases, you can have a palpable spleen as well. That is a point. Okay. In a setting of obstructive jaundice with the
or the spleen might have been enlarged right from beginning. It doesn't matter. It's unrelated. Right? Yeah.
Okay. Go ahead.
Next slide. Okay.
Sorry, I had to the systemic examination. On CVS examination, the
That's
S1.
fine. Okay, it's okay. That's okay. Nothing there. Move ahead. We've got 15 minutes to discuss your management. Go on. Next slide. Okay, how do you manage this? Patients come to your OPD with these symptoms. What do you do now?
Sir, I would like to do some investigations. First, I would like to do investigations to confirm my diagnosis. Over here, I would like to do a USG whole abdomen.
Okay, you got the USG report?
USG, we don't have the lab.
You got it? You don't have it. Okay, what are you looking for in ultrasound at the moment?
On USG, first I would like to look for any look at the CBD, sir. The diameter of the CBD, if it is dilated. I would like to look
Okay,
into
why do you think the CBD? Suppose I say the patient was not of obstructive jaundice and the CBD is dilated. Can you relate it to this patient?
Patient is old aged and post cholecystectomy both. So in both cases,
Right.
We can have normal
The
dilatation.
CBD. So why are the first thing you're looking for is dilated CBD, which could be a physiological post surgery, old age. What is more
I would
important
look at the liver ecotexture, ISBRD.
Oh dear. Manish, aren't you going to look for any lump in that region?
Yes, a lump in the GB fossa.
So the first thing you look for what is going to cause that problem, right? Then you
Lump
look
in
for
the-
liver and spleen and lymph nodes and all that kind of thing.
You can see ascites. You can see the CBD status. When will you call a CBD a dilated CBD in this age group? In this age group,
Normally, by up to 66th decade, the CBD is 6 millimeters. After that, with every decade, 1 millimeter increase in the diameter of CBD is there.
So was the CBD dilated? Do you have an idea? No. You don't
In the
remember.
CT,
Okay.
yes, CBD is dilated.
No, ultrasound was done or not done?
Ultrasound was not done. So the patient had CT. So.
No, I mean, why should an ultrasound, a CT be done before an ultrasound? I can't.
Yes.
This is becoming quite a common phenomenon these days. People walk in. Did you get so you also didn't get ultrasound done?
So patient is just admitted with us. So we have the
No. The patient CT was done at your center,
Yes.
or he came with the CT from outside?
He came with the CT, sir.
So should he get ultrasound or not?
Yeah. There was usually we follow the protocol of doing a USG after admission. This patient was known to someone, so he had gotten a CT from beforehand before coming to our OPD.
Okay, Dr. Manish, that's not the point. The point is that what is the importance of ultrasound here now?
Ultrasound, sir, it can initially only tell us that the disease is malignant, so we can avoid a CT and go for biopsy from a liver.
No,
I'm asking you,
Dr. Manish.
No.
Please understand
ultrasound
the question.
Has its own importance.
Yeah.
What can be picked up easily by ultrasound, which a CT cannot.
Yes, gallstones.
Yeah, you could have missed a gallstone, silent stone sitting in the CBD. and you're beating the drum about CA head of pancreas,
Yes.
right? Okay. So
After ultrasound,
you've done an ultrasound, then what?
then what
Then
next?
Next, I would like to do investigations to stage the disease, in which, in this case, I would like to do a
Hang on. You've got a ultrasound, right? You have to do some blood tests now. You can't do a CT without a blood test, right? So what are the blood tests which are of importance here now?
I would like to do routine tests, and beginning with LFT, sir. In LFT,
Okay.
I would look for the
What is
total
the test
bilirubin.
for which distinguishes between direct and indirect bilirubin? What's this test called? Back to your days of biochemistry.
Yes, sir.
Vandenberg test.
Van der Waals test, yes.
Okay. So you've done these tests. What else will you do now?
Other than LFT, I would like to do a PTINR, a CBC, a KFT, because we might proceed with
No,
the
can you give us the findings on the what is the values on the LFT?
blood investigations are there in the next slides.
No, tell us what was the LFT fund. Yeah.
Yes.
So in the LFT it was bilirubin 27,
Man,
Yes.
direct 14, ALP and okay.
right. What else?
Why did you go for CA 19.9?
It can not only tell us a diagnosis, its values have diagnostic significance, but also it is a tumor marker, sir, which is raised in
So
hepatobilirubinemia.
you have not confirmed your diagnosis yet. You mean to say you will go for the tumor markers before the CT scan, before ultrasound guided FNAC, you will go for these markers?
No, so we should go for it after the confirmation of the diagnosis.
Yeah, these are the it's difficult to use them for the diagnostic purpose. You mean to say if you have a raised CA 19.9, you will presume that it is a periampullary carcinoma or carcinoma head of the pancreas without its evidence on the CT or on the histopathological examination?
No, sir.
Manish,
How will you
Manish, it's
confirm your
the
diagnosis?
safest. Sorry. Manish, it is safest in an exam to tell what you do, right? We usually do the right thing in your hospital, in your ward. So do just say that, right? That this is what I have done. You'll never be wrong. But if you try to do it by theory, you usually fall in a trap. Yeah. Next.
Okay, from LFT, what are the what all things you can understand from the LFT? Let's proceed. One is you can see the raised bilirubin, and you can see the enzymes.
First, yes, sir. First, we'll look at the bilirubin and see what is the ratio. How much is the direct bilirubin to see first it is a obstructive jaundice, direct hyperbilirubinemia. Following that, we will look into the enzymes, sir, and
Here it is almost equal. Direct and indirect is almost equal, 14 and 13.
yes.
What about
What other
alkaline
enzymes?
phosphate, Manish?
Yes, sir. Pardon, sir.
What about alkaline phosphatase? What is significance of raised alkaline phosphatase?
ALP and GGT. ALP is raised in obstructive jaundice cases.
And
Apart
what
from that,
about GGT?
GGT is more specific for liver, and it can be more specific because ALP can be raised in other conditions also.
And GGT is also raised in which conditions? In which liver pathologies most commonly?
In alcoholic liver disease.
And in obstructive jaundice also, GGT is
obstructive
raised. And if there is a raised alkaline phosphatase, we raised gamma GGT, means it is obstructive jaundice if there is no history of chronic liver disease. Right?
how about the albumin protein in this case?
It was 3.5, but I have not mentioned. Sorry, sir. I should have mentioned 3.5.
Is it important? Is it important?
Yes, sir. It helps us to understand the nutritional status of the patients.
Right. So okay. So now
Manish?
let's come to your management. Sorry.
Manish,
So
why clotting is deranged in obstructive jaundice?
In obstructive jaundice, there is decrease in fat-soluble absorption of fat-soluble vitamins like A, D, E, and K, and vitamin K is involved in clotting in the activation of clotting enzymes or
The
clotting
gamma
factors
carboxylation.
27-9-10,
Gamma
gamma
carboxylation.
carboxylation of 27-9-10, which takes place in the liver. So since that is not happening, there's deranged INRs.
And how to correct the clotting abnormalities?
Initially, we can give injection vitamin K. We can supplement vitamin K,
Okay.
and either IM route or IV route for 3 days, 10 milligram.
Okay.
Any other?
Okay, Manish. Right, go on, please. Just answer.
Okay, sir.
If it is still not corrected, we can go for FFP transfusions. If procedural.
When does vitamin K infusion, vitamin K injection do not work? In which scenario that happens? If the liver cannot utilize it, if the patient is already into
liver
failure,
cirrhosis, biliary cirrhosis.
then what will you do in that case? You have
In
to
those
optimize
cases,
the
we have
patient.
to go for FFP. We have to transfuse FFPs.
Okay. If it's not happening,
Okay,
you
Manish,
have to consider.
you have got this patient
factors.
now. You have admitted him. Now, what are the instructions? What do you do now? You've got send the bloods. You got an ultrasound. Till is waiting. What do you do for the patient? What are the factors which you have to keep in mind in managing this patient?
Firstly, I will look into the hydration of the patient, sir.
Very good.
If his appetite is good, I will try to give him oral fluids, or if he's dehydrated, I would like to give IV fluids.
Why is hydration important?
Because patients of obstructive jaundice are prone to AKIs.
Okay. Hepatorenal. Okay. What else?
Hepatorenal
What is
syndrome.
hydration? Next. You've given him fluids. What else will you give him?
Next, I would also
Vitamin
like
K
to
you've
give
given him.
vitamin K.
Okay,
I would like to
these
give
two is done.
antipruritic agents.
What?
What all will you give? Because it's a very difficult
do you
symptom to manage.
What do you give?
To begin with, antihistaminics are given. And
Okay.
Does it really work? Will it work?
They have not been found to work as such. We can give
So which is the
polystyrene.
drug? Which is the first line of drug you give? What is the first drug you give?
Levocetrizine, followed by we can give polystyrene sachets.
Bile exchange resins.
Okay, cholestyramine. Then next line doesn't work. Cholestyramine. Next,
we can give opioid.
Anti-opioid, not opioid.
Anti-opioids.
Yes.
Anti-opioids.
Which are the drugs?
very important.
You can give naloxone,
Naloxone.
These have been tried.
Okay, before that you give UDC.
Absurd.
Right?
Yes.
After that, the third line is rifampicin.
Yes.
Then this fourth is anti-opioids. Okay. So, okay, you've done that. What else? Hydration, coagulation, itching. Anything else?
Anemia, if it is there,
Nutrition.
you have to correct that.
Okay. Anything else?
Nutrition and nutrition of the patient, I would like to do.
Okay. Very good. How do you assess? How do you assess nutrition and how do you manage nutrition? Quick.
We can look into the albumin levels. We can.
So you have two systems: anthropometric and biochemical.
Yes.
Right. Both of them will assess accordingly.
Anthropometrically, we can have a. There can be BMI.
No, it's okay. We don't have time. What else? Nutrition. What else do you take care of? Infection.
Would you like to?
Infection, yes.
So you've got to give antibiotics.
Yes.
So hydration, infection, nutrition, coagulation, itching, right? Then you get a CT. Let's see a CT.
How do you know about the importance of EUS, endoscopic ultrasound, in a case of obstructive jaundice? For completion's sake.
EUS can help us characterize the smaller lesions which are not properly seen in CT. Also, lymph nodes can be better visualized and vessels can also be visualized.
No. You mean if you get a CT and you don't see a lump or a mass in the pancreas, then you go in for EUS. Or what are the indications for EUS?
If there are contradicting findings on CT,
What contradictory findings? Okay, let's get to the CT finding first. Let's
Yes.
get
Go to
Yeah,
the CT. Go to the CT.
investigator.
Yes. What is the method? What is the interpretation?
sorry, I didn't get the question.
Now, in a case of obstructive jaundice, you have a differential diagnosis. Now, your first possibility is a
Periampullary carcinoma,
periampullary. Second possibility,
head of pancreas.
head of pancreas. Anyway, you are working in that area, so you are going to do a CT. What is the type of CT that you perform? Is the regular your routine CT, or is it a particular methodology there involved there?
I would like to go for a CT abdomen with pancreatic protocols.
Yes.
So
Can
you would do a
describe that?
pancreatic protocol in all cases of obstructive jaundice.
No, so in cases where I suspect that I want to, there is a pancreatic lesion present, I would
Exactly.
history and physical
So
examination.
in your this CT, will you do a pancreatic protocol?
Yes, so because my differential diagnosis are kept as a periampullary carcinoma.
Yeah, because it's abutting the head of pancreas, right? Okay, go on.
Any
So,
idea
please.
about the CT, pancreatic CT?
Yes,
If you know,
it
it's
is
okay.
it is usually done with a 64 multi-director system with preferably 1 to 0.5 mm slices, or but less than 3 mm slices, with a oral negative contrast to distend the stomach and the duodenum.
Oral negative or neutral contrast initially. What do you
Neutral.
give? Yeah.
Water.
What do you give? Water or mannitol?
Mannitol
Around
can also
800 ml of water you can use.
800 ml of water
Yeah.
or mannitol, and along with that we can give iodinated IV contrast is given at 1.5 milligram per kg at a rate of 3 to 5
IV contrast
ml
are you
per
using?
second.
Which
And
IV
then
contrast are you using? What type of IV contrast are we using?
IOHEX also.
Yeah, water soluble iodine contrast, right?
Sorry.
4 to 6 ml per second. Yes. So which are the phases? Just complete it. Complete the answer.
Initially,
Which are
we'll
the
have
phases?
a scout film with the NCCT taken at 0 seconds. If we are suspecting NET or pseudoaneurysms, then we can go for a early arterial phase at 10 to 15 seconds, followed by a late arterial phase at 30 to 40 seconds, followed by
That is the pancreatic. What is the other name? Pancreatic?
pancreatic parenchymal phase, and
Yeah, 30
next
to
is
40
the
seconds. Yes.
portal phase at 65 to 70 seconds, and yes,
You can
sometimes
visualize the
the delayed phase
neuroendocrine tumors as well. During the last phase, you can visualize the neuroendocrine tumors as well. So that's how you do this. Okay. Right.
What is double contrast CT? What do you understand by that? What do you understand by double contrast CT?
In which we give a oral negative contrast and an IV positive contrast.
What is a triple contrast?
I don't.
Okay, where you give the rectally also. If you give the contrast rectally also, that is the triple contrast. Now in this patient, if you have a choice between the MRCP and the CT scan, what is your choice?
So since I'm suspecting malignancy, initially I would go for CTs.
No, if your ultrasound shows that there is a proximal CBD stricture or lesion, then you will like to go for CT or MRCP then?
Then I would like to visualize the biliary tree better, so I would go for MRCP itself.
So for proximal CBD pathologies, MRCP is superior, and for distal CBD and pancreas, CT abdomen is a better investigation, right? So that's why the ultrasound is important. Omitting the ultrasound may end up with unnecessary CT or sometimes unnecessary MRCP, right?
So what are the various advantages of having the MRCP over CT or CT over MRCP?
MRCP
One,
can
Dr.
show us
Notial has
the
told you about the proximal and the distal one. What are the other things which are
Other.
there?
Yes.
intrahepatic lesions or liver lesions can be better identified in MRCP. And vascular relations can be seen better in CT.
It's mainly the local resectability which is there and the vascular invasion which is there, which will be much better seen on CT scan as compared to the MRCP. MRCP mainly for the intraluminal. That is, a stricture is there or intraluminal mass is there, then in that case, definitely the MRCP is the choice. Which contrast do you give in MRCP?
Normally in MRCP we will not go for any contrast, but in contrast enhanced MRI, if it is there associated, if we are doing an MRI also along with it, so we can give gadolinium.
So what are the situations where you have to give the contrast?
Especially in liver lesions that are not characterized properly, so we can go for a contrast enhanced upper abdomen MRI to that is gold standard for identifying liver metastasis. It is doubtful on CT.
Okay. Yeah,
What you will do next now, Dr. Manish? You have this CT
Like to
finding.
go for ERCP? Would you like to go for ERCP?
There are yes, we can either go for upfront surgery or we can go for biliary drainage followed by surgery if the tumor is resectable on CT.
No, you have not proven so far that it's a tumor. What will
Yes,
be the next step? Sir has given the hint.
if
There is a
we have not
thickened
proven, we will go for
CBD, है ना? Mid CBD के बाद में there is a thickening.
yes.
So what is your next step?
We can go for a EUS with ERCP and brush
So
cytology.
how EUS will help you?
It can visualize the distal CBD better.
No, it is written in the CT that after mid CBD there is abrupt cutoff, like obstruction and thickening of the distal CBD. It is written.
ERCP.
What you will do with
brush cytology.
ERCP? Brush
I would-
cytology. Yes. So one thing is brush cytology, right? And if that is negative, then you can go for EUS guided FNAC from this
FNAC.
thickened. Yeah. So now what is your diagnosis based on this CT? Is it periampullary carcinoma or something else?
Currently, looking to the CT, we still have to discuss the CT, but according to the report, it's distal cholangiocarcinoma.
Yeah, so it is from the CT it appears because pancreas head is normal and it cannot be periampullary where the lesion will ascend upward towards the till the mid CBD. So it's a distal cholangiocarcinoma. So the clinical presentation in the cholangiocarcinoma in some patients, what is the picture? What is the relation of itching with jaundice?
Itching precedes jaundice in
May,
cholangiocarcinoma.
not in all cases, but in few cases, itching may precedes months before the appearance of the jaundice, right? So next is sir asked, what you will do with the ERCP? One is the brush cytology. Another thing, anything you want to do more?
Since the bilirubin is 27,
Hmm.
and we are already going ahead with brush cytology, I would like to go for a stent also placed.
Why you want to put a stent? Or it is any case of obstructive jaundice where you are going for the definitive procedure like Whipple's or cholangiocarcinoma? इसमें भी Whipple's ही जाएगा because distal CBD is involved. So do you stent each and every patient? What are the indications for stenting in the case of obstructive jaundice where decision is already made for Whipple's procedure?
In preoperative phase, if stenting is needed only if there is cholangitis.
No, what are those indications? Yeah.
Cholangitis, if there is cholangitis.
One is cholangitis. Then
second, if the patient is going for
Bilirubin is
NSCT.
27.
Yeah.
Right? Bilirubin is 27. That is
27.
why I asked that question. What is the role
Yeah.
of ERCP, right?
Yes. Dr. Manish?
Yes.
Hello. Please
Yes.
answer that question. Sir has given you the hint also. What are the, apart from cholangitis, what are the other indications?
First can be cholangitis. Second can be if the patient is planned for NACT or the patient is being rehabilitated and will need time before surgery.
CT has been done.
Or
We are talking of this patient. No?
and this patient, since bilirubin is more than 20, usually cutoffs are taken. More than 20, patient is not operable at that stage, but
So
they
in the
vary from.
high answer should be in a high bilirubin level.
Why not?
Stenting should be done. Usually, if it is around 15 and you are contemplating surgery within a week, then there is no indication of palliating the jaundice with putting a stent. Why it is not advised?
It can first is that it can cause intra adhesions and difficulty in
Adhesions.
dissection.
How it will cause adhesions? You put a stent and you operate on the second day because you are already decided for the procedure.
Uh,
It will rather
It
help
can-
you in during the surgery in identifying the CBD on those structures.
and
Why it should be avoided?
it has been shown to cause increased SSIs.
Yes,
Or
surgical
infections.
site infection, increased infection rate. Yeah, but if it is high, then why it should be stented, like in this case of 27?
To prevent the perioperative complications of
How raised bilirubin will prevent the perioperative complication? कुछ cardiac complication होती है high bilirubin से? क्या होता है?
High bilirubin can cause cardiomyopathy. Increase the risk of perioperative cardiac events.
Sinus node, it affects the sinus node suppression
Sinus,
causes, and there's
bile
a
salt. Yes.
yeah. So that's why the high bilirubin level you should stent and then go for the surgery, right?
What are the other absolute indication for ERCP preoperative drainage except cholangitis? If patient is having, if patient is not having, if patient is having any other problem other than cholangitis, would you like to stent patient? Any other indication except cholangitis for preoperative drainage?
If the patient is borderline, I'm planning a NACT.
If you are planning a NACT, okay, that is one indication. Other? Intractable pruritus is also one of the indication where you can stent preoperatively. Okay.
Manish, what was the pulse rate of this patient, by the way? I was not there at that time. What was the pulse
76 beats per minute.
So why there is a bradycardia in the patient with the jaundice?
Bile salts are seen to deposit not only in the SC node but also in the junctional tissue of the heart. That increases the QT interval and causes bradycardia.
What else?
Uh,
I'm just asking in relation to Dr. Nautia's question.
Obstructive jaundice can also cause increase in the intrahepatic pressure, so that kills the Kupffer cells, which are responsible for taking out the endotoxins. So endotoxemia and can usually can go and cause cardiomyopathy as a whole, causing some activating some molecular pathways that can cause apoptosis of cardiac muscles, causing cardiomyopathy in
What is that factor called as?
caspase.
It is myocardial depressant factor.
Depressant.
Okay. And that is why you have to take care of the bilirubin, apart from all those things. So what is the effect on vagus of the high bilirubin?
Vagal stimulation is there.
That is
So
why
that
there
also causes
bradycardia is
bradycardia.
So these are all the reasons for the bradycardia. Okay, go ahead, Ian. I just wanted to. So what is your further plan now in this patient?
I would like to investigate the patient further by doing a risk assessment for cardiac and pulmonary risk assessments.
Do you want to do any other investigation for making the diagnosis?
In this case, we can go for a ERCP with a breast cytology.
No, that we have discussed about that. Yeah. Any markers?
Yes,
You
CA
discussed about that.
99, CEA can be done.
Yes.
Something
What is
else.
the role of in this case?
More
Wrong
interested
if,
in CA or something else?
CA 99.
Yeah, CA 99.
19.
Yeah, you're more interested in that.
So what is
C is the general
what?
mark.
Yeah. What purpose it will serve? Even
in the
if you have a
diagnostic,
one. Yeah.
in the diagnostic phase, if it is more than 100, it is suggestive of a malignancy, and if more than 1,000, it is suggestive of a metastatic disease. And later on, it can also give us indication of recurrence and response to chemotherapy.
It is a prognostic
And this is
marker
a
also.
baseline. Yes,
Yeah.
prognostic.
High values are associated with poor prognosis. Right. So it is a prognostic marker also. Right.
What
So
is the
what
value
is that?
of CA in this one? What is the
Yes.
value of CA in pancreatic carcinoma?
Sometimes in patients, CA 99 is not raised because of absence of Lewis antigen. So in those cases, CEA can give us a
CA
indication,
can be taken as a prognostic marker, not a
Prognostic marker.
diagnostic marker, but a prognostic marker. If the CA is raised and it is coming down, probably you have cured the patient, but if it is rising again, so it's a prognostic marker rather than a diagnostic marker. Okay.
I think we are running short of time. Dr. Kanagavel has put a message there. So what is the next thing? What is the next plan about this case?
After optimizing the patient by getting all the risk assessments done and a pre-anesthetic checkup done, I would like to pose the case for explorations.
Exploration.
In this case, exploratory laparotomy with a pancreatic odour.
Why you are using the term explorated laparotomy in this case?
Initially, when we go for laparotomy is done, we first identify if there's any signs of occult metastasis. Followed that, we proceed with the
Occult?
pancreatic odour.
How you will see occult metastasis? You better go for laparoscopy.
Indication of staging laparoscopy is only if the tumor size is more than some certain indications are there, like if the tumor
No,
size
my
is more
question
than
is don't say exploratory laparotomy. You have there's
pancreatic.
no lymph at such no signs of metastasis, so you can directly go for the people's procedure, planned procedure.
Resection.
And if you have any suspicion on the CT scan or MRI, there could be stage 4 disease, then better go for the laparoscopy and look for liver mets, peritoneal mets, mental mets, and then proceed for Whipple's procedure. Right?
Not use the word exploratory laparotomy.
Yeah.
Exploratory laparotomy is done. Diagnostic laparoscopy.
Yeah.
You'll go ahead with a diagnostic laparoscopy and then go ahead and decide.
With the definitive procedure, yeah.
Dr. Manish, always you can go for diagnostic laparoscopy in periampullary malignancy to avoid unnecessary laparotomy. Sometimes 30% of cases you can avoid laparotomy. Sometimes you find advanced disease. So better to go for diagnostic laparoscopy first, followed by laparotomy.
Yes.
So are you going to prepare your patient?
In preparation of the patient, initially I would like to hydrate the patient, keep adequate blood products should be arranged, vitamin K should be given.
I think that part was already been discussed already.
Okay, that's fine.
Optimization was done already.
Right.
So
go ahead with your treatment here. What treatment you're going to do?
We would go for a pancreatic urinectomy.
So what are the various steps of pancreatic urinectomy? Main steps.
Initially, after laparotomizing the patient, either via a chevron incision or mostly a chevron incision, we would go for cauterization up to the left renal vein, and then after that we will look after that we would like to open the lesser sac by opening the gastrocolic ligament.
Any idea about cattle brush maneuver?
Yes, the cattle brush maneuver can also be done if which is the right colon is mobilized to get a
Yeah,
better
the hepatic
visualization.
flexor is mobilized, and
Yes,
you come all the way, white line of thought. You can see the IVC,
IVCs.
aorta, and you can look for the aortocaval nodes.
He has
Yes,
gone up to the left renal vein. Hai na? He has already gone up to the left renal vein. It means he has already seen the cava and the aorta. Yeah, right.
you see the
Okay,
cava,
yeah.
aorta. Then what is the decisive? When will you make the decision?
We we will be dissecting around the SMV and SMA and see that if they are free from tumor, and the tunnel of love, we will try to see if there's any additions in that, and then we would go for after that we have seen that the vessels are free, then we can go for the gallbladder can be um, separated from the gallbladder bed, and then dissection around the uh, common hepatic duct with all the soft tissues it can be skeletonized, and then we can go for a transection of the common hepatic duct just at the point where it meets just above the point where it meets the bile duct, and after that we can go for then after that we will be going for a transection of the jejunum around 10 centimeters of jejunum after DJ, and then we can mobilize the jejunum by dividing the ligament of Treves by taking care of the IMV which can be there nearby. We have to ensure it's not injured, and then we can divide the duodenum, divide the stomach in classical pancreaticoduodenectomy, just proximal to the pylorus, and after that the final step of dissection is done. Also, we have to divide the neck of the pancreas, and some centers also send by a frozen section from the neck. After this, we can proceed with freeing the head of the pancreas from the remaining attachments with the portal vein, and the specimen is delivered. Then we go for the
What you want to see
reconstruction
in the
step.
specimen? What are the things you want to see in the specimen? Cut end of the specimen.
The diameter of the MPD.
Okay, so how does that matter?
It helps us to decide what type of pancreatic jejunostomy or gastroscopy we have.
Okay, so how do you decide that?
If the if the pancreatic tissue is soft and the duct is small, we can go for invagination technique or a dunking technique of PJ. If the duct is large enough, we can go for direct duct to mucosa type of PJ. But again, it comes down to the indication of the preference of the surgeon, because it's been seen that method they practice is one.
Okay, if the cancer has developed over the chronic pancreatitis, if you do the anastomosis, is it more likely to leak? Or if it is without the pancreatitis, it's more likely to leak?
If it is with pancreatitis, it is less likely to leak because the gland becomes firm.
Good. So it's a firm gland is there, a fibrous gland is there, so less likely to leak. And then you have to see the diameter of the pancreatic duct. How does that decide your anastomosis?
Yes, if the duct is small, we have to go for dunking, in which we invaginate the duct into the jejunum, so that because the duct to mucosa, direct duct to mucosa PJ cannot be done easily. It is
Anything
very
else which can be done? Anything else which
If
can
the
be done?
diameter is mostly if it is more than 5 mm, 3 to 5 mm is a gray zone, and if it's less than 3 mm, we can
No, apart from the jejunum, can you use something else?
we can use stomach also if gastro pancreatic gastrostomy can be done. Uh, Pancreatogastrinostomosis can be done in soft pancreas or a small duct, because it has increased blood supply. It has the pancreas which leaks. It is the enzymes are deactivated by the stomach acid, and it is easier to invaginate in stomach mucosa.
Okay. What is the advantage of preserving the pylorus?
Pylorus preservation has decreased chances of DGE. Other than that, it's comparable to pancreas not classical pancreatic.
What is the most dreaded complication? I think we are getting short of time. Most dreaded complications after Whipples.
Dreaded, sir?
Most difficult to treat complications after Whipples.
POPF, post-operative pancreatic fistula is one.
Post-operative. Yeah. Which leak is the most difficult to manage?
Pancreatic fistulas.
How do you diagnose a pancreatic fistula? What is the criteria or what are the guidelines clinically?
According to ISPGS guidelines, they say previously it was that only on after POD3, but now on any POD, if the drain amylase is more than 3 times the upper limit of the institutional amylase level, serum amylase level. This is just the biochemical guideline. After that, this is the biochemical leak. If there are clinical symptoms in the patient in which there's pain, or if without any organ failure, then or any need of reoperations or any mortality, then it is grade B. Only endoscopic or interventional radiology interventions are needed for this. And if resurgeries are needed, it's type C.
Fair enough. Kanagavel, sir? Over to you, sir.
Sorry. Actually, the discussion is going good only, but unfortunately, we have to give equal weightage to the second candidate also. Manish, I think you were able to face the examiners fairly well. Do you have any doubts to be clarified with the national faculty here?
Yeah, yes. So one thing was that I wanted to find, should we mention pallor we checked or not? Because in jaundice, like some examiners say that we should not check for pallor. We can say it is.
Come again, check for what?
Pallor, sir. Pallor in uterus.
Pallor in a jaundiced patient.
Yes.
No, we should not mention, Ashish. Manish.
Yeah, you should not mention.
We should not mention.
Pallor can only be seen if there is no jaundice. Once it is yellowish in color, how you can say it is pale in color? Then it's better not to be commented, right?
Yes.
If some examiner is very particular about it, you can.
Yeah.
Manish,
if some examiner is very particular about it, you can talk about the undersurface of the tongue. I have heard some examiners waiting for that answer to come.
Yes, sir.
Yeah.
Yeah, Manish,
actually, it's quite redundant.
If
you're going to do a CBC, I mean, this is just an academic discussion, not relevant, really relevant clinically. Okay, so don't worry about it.
Thank you, Dr. Manish. I think you
Very
have
well done, Manish.
highlighted about the areas where you find difficulty. You go back to the library and catch up those areas. That's how all of us try to improve upon. And I thank Dr. Amit sir as well as Dr. Som Prakash sir for permitting you to join us this evening. Thank you very much. And I wish you could stay back for the next case discussion also if you are not on call or something. Dr. Ramchandra is kindly being contributed by Dr. Professor Guru Shantappa, Professor and Head of the Department from KIMS Hubli. Dr. Krit Palmer has some religious requirements, functions coming up. So, sir, kindly take leave. You have been asking from the time we called you up also. Please feel free to leave at your convenience. Sir. And thank you for joining us this evening. So, Dr. Thank you. Ramchandra, please introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you. I think Dr. Guru Shantappa is also there, sir. Please welcome you also, sir, for the discussion.
Yes, sir. Good evening, sir. Kanagavan, sir. Good evening.
Good evening. Thank you, sir. Thank you for joining. Yes, Ramchandra, good luck to you. Please start.
Yes. Thank you, sir. So, good evening, sir. I'm Dr. Ramchandra, sir. My guide and my unit chief and HOD is Dr. Guru Shantappa Elagachin, sir, professor and HOD of the department, General Surgery, KIMS Hubli, and is principal of KMCRI. And I'm sharing the screens. Shall I proceed, sir?
You are good to go, ma. Good luck.
Yes, thank you, sir. Here I'm presenting a swelling case presentation on the swelling in the neck. Here, patient details are, here is my patient, 64-year female who hails from Kamanadi from Karnataka,
Hello?
and she's a daily wage worker. Her chief complaints are swelling in front of the neck since 10 years, rapidly increased since 2 years, hoarseness of voice since 6 months, choking sensation on lying down since 6 months. Patient was apparently well 10 years ago. Then she noticed a swelling on the left side of the neck, which was of size about 2 cross 2 centimeter, and gradually increased in size to about 3 times over 8 years, and rapidly increased in size to about 5 times over 2 years. Patient complains of hoarseness of voice since 6 months. Patient complains of discomfort while swallowing since 6 months. Patient complains of choking sensation on lying in supine position since 6 months. There's no history of there is no history of hyperthyroidism or hypothyroidism. No history of any other swelling in the neck. No history of recent onset of bony pains. No history of hemoptysis or breathlessness. Patient is a known case of type 2 diabetes mellitus since 6 years on oral hypoglycemic drugs, and patient is a known case of bronchial asthma since 20 years on metered dose inhaler. There is no significant family history or any significant family history in the neighborhood. Menstrual history. Patient had menarche at the age of 15 years, and she has attained menopause at the age of 50 years. Her obstetric history, she is para 3, living 3, and all are full-term normal vaginal deliveries. Her diet is mixed, and appetite is normal, sleep is sound, bowel and bladder are regular, and there are no habits of consumption of any addictive substances. To summarize, an elderly female, known diabetic and asthmatic, presented with complaints of swelling in front of the neck since 10 years, which rapidly progressed over past 2 years to attain the size of about 5 times and with the initial size of about 2 cross 2 centimeter, with complaints of hoarseness of voice, discomfort while swallowing, and choking sensation on lying in supine position since 6 months. Should I proceed with the general physical examinations?
You have been always saying since. I think probably that is not correct.
Yes, sir.
Okay. You know, when do you say since and when do you say for? Okay, you have been always in, I think probably you have, at 10 places you have mentioned the since. It should be for. No?
Yes,
Since
sir.
is a definite thing that
Yes.
it is since 5th of July. This has
Yes.
happened. But it is for years together is there, then it cannot be a since. No?
Yes, sir.
Okay.
Yes.
Yeah. Then how did the patient know that it grew 3 times in this period and then 5 times in this period?
Sir,
How can the patient calculate that?
Initially, she showed a size of about she showed in finger size about 2 cross 2 centimeters, sir. And she had said that about 3 times, roughly around about 3 to 4 times of the initial size it has increased, and recently it has increased still more, two more times than
Dr. Ramachandra, is it important? Is this important? 3 times, 5 times, 8 times?
No, sir. Just
Is it important?
What is the difference
Just the
between
timeline is
sudden
important.
increase and rapid
3
increase?
times or it's 4 times or 5 times, it's not important. It is the rapidity by which it increases and the time it takes to increase. That is important, right? So don't stress on this. Professor Khan is obviously picking on you for this now.
Yes.
Right?
Yes,
So
sir.
in your examination, don't write all these kind of things which are slightly unusual.
Yes, sir.
Right?
Ramchandra,
Yes, sir.
in your history also, biodata of the patient, you are mentioning that name, age. This is not the way to present the case. It should be in ideal set, in only one line.
Yes, sir.
Because this is PG exam.
Yes, sir.
Okay, proceed.
What is the difference between a sudden increase and rapid increase of thyroid swelling?
Sudden increase might be because of any hemorrhage, sir. Hemorrhage in the thyroid nodule, so rapid increase.
The question is not what is the cause. He's
What is
asking
cause
what
of,
is the
sir is
difference.
asking what is cause?
What is the difference between the two? Cause is later.
Sudden increase may be within span of 1 or 2 days, sir. Rapid increase may be within span of or weeks.
Sir is asking, not asking span. Sir is asking what are the causes? What you suspect? Suppose patient gives history of sudden increase in size.
Sir, I would suspect a hemorrhage into the one of the nodule of the thyroid glands.
Okay.
And
Any
rapid?
other?
A rapid increase, I would think of malignant transformation as one of the cause.
Okay, go ahead, yeah. Here is my
yes, sir.
Please go to negative history. First slide. You have mentioned that there is no history of hyperthyroidism and hypothyroidism. Why you ask?
Sir, I asked for the symptoms.
And which questions you are asked regarding to evaluate to rule out history suggestive of hyperthyroidism or hypothyroidism?
So in case of thyrotoxicosis, and if the patient is giving complaints or any symptoms,
Hey, how you
if she is
elicited
complaining of
history? How you elicited whether patient is having hyperthyroidism or hypothyroidism?
Sir,
How you asked history?
I asked for any recent any history of weight gain or weight loss, or is there any history of whether the patient has any palpitations, or whether the patient is whether there is insomnia, or whether the patient is anxious, or sweating is or any sweating is present, or hair loss.
And hypothyroidism?
Sir, any history of weight gain, or whether the patient is
Specific question we
constipated?
supposed to ask to rule out history of hypothyroidism, or which specific question we supposed to ask to rule out history of hyperthyroidism? This is history protocol.
Sir, I couldn't get this.
Hello, which question we supposed to ask to rule out hypothyroidism?
If we are suspecting any obese patient, then we'll be trying to rule out. If the patient is obese, then
But
we'll
how
be
will
trying.
ask the patient?
Any recent onset of weight gain, like whether her clothes are becoming tight, or and whether the patient attenders are seeing her, she has gained the weight on based on those
Okay.
history.
What is primary hypothyroidism? What is secondary hypothyroidism?
If thyroid gland per se is not secreting any thyroid hormones, then it is primary hypothyroidism. Secondary hypothyroidism might be because of
Investigation-wise, how will you differentiate between primary hypothyroidism, secondary hypothyroidism?
in case of primary
Clinical.
hypothyroidism, TSH will be higher and T3, T4 will be low. In case of secondary hypothyroidism, even the TSH will be low and T3, T4 can be will be low.
What are the clinical signs of hypothyroidism? And which is the diagnostic sign for hypothyroidism?
Sir, the patient will be having there will be knee jerk will be there will be a decreased reflex of knee jerk, sir. It can be one of the sign of hypothyroidism, and now patient will have a history of weight gain. Then
there is beautiful sentence given in rule of Bailey. Everything is slow along with tender calyps.
Yes.
So delayed tendon reflex is a sign.
Yes.
Then why you ask history of bony pains, recent onset of bony pains, hemoptysis, breathlessness?
So to rule out any metastatic history, I have asked for recent onset of any bony pains or hemoptysis or breathlessness.
Okay. What you are suspecting from your history?
So I'm suspecting multinodular.
From history.
Yes, sir. From history, I'm suspecting a benign etiology of benign etiology of thyroid swellings.
Thyroid swelling.
Yes.
How will you exclude the malignancy in this patient? It is not mentioned in your negative history. No history suggests of hyperthyroidism, hypothyroidism. Again, there one more point. There is no history suggests of malignancy. So,
Yes,
which
sir.
history we supposed to ask to rule out malignancy, particularly anterior neck swelling, this
So
thyroid swelling?
there are she gives a long prolonged history of the swelling in front of the neck, sir. So
Okay.
that and the other compressive symptoms like hoarseness of voice and difficulty in breathing, difficulty on lying down in supine, breathing in lying down in supine
Is there
position.
any role of history of irradiation to the neck?
No, there is no history of any irradiation to the neck, sir.
No. Is there any role of irradiation in neck?
Yes, sir.
Irradiation
Yes.
to the neck in
Yes.
this patient?
Yes, sir. Yes,
You have
sir.
not mentioned it.
Yes, sir. I should have mentioned it.
Huh?
Yes, sir. I should have mentioned it.
Okay.
So,
What is
in
the-
which, how you will ask the history from the patient regarding neck radiation? Why it is important?
So if usually papillary thyroid carcinomas are
No. In this patient, the patient developing a rapid increase in the neck swelling or a neck swelling appearing in the patient. Why history of neck radiation is important?
Sir, if the patient was previously exposed for radiation, then we would think of papillary thyroid carcinoma.
Previously exposed how?
Long in case of her childhoodness, then childhood for any treatment for acne vulgaris or any treatment for
More commonly it is given for. Do you think acne vulgaris radiotherapy is given commonly?
At present.
no.
Usually for which diseases mental radiation is given to control that is?
For lymphomas, we'll be giving
Lymphomas, yes. So that
Lymphoma.
lymphomas. Okay, yes. Obviously, for the acne also it is given, but the dose is not so much that it may cause. It can cause theoretically. And after how? What is the duration after the radiation that it may lead to development of the thyroid malignancy?
So it should be more than 20 years. Then we'll be thinking of we might suspect.
Yeah. So exposure should be
Yes.
minimum 10 years ago. Huh? Okay. Okay, proceed.
Dr. Ramchandra,
Yes,
just
sir.
come back to previous slide.
Yes.
Here mentioned sleep is sound. What does it mean?
Sir, when she sleeps in supine position, she'll be having difficulty for breathing, sir. But when she sleeps in on the lateral position, then the patient will have a normal sleep, sir. So she doesn't complain of disturbed sleep, sir.
So whether sleep sound is a proper terminology, or you should mention like sleep is adequate or inadequate.
Yes, sir. Adequate sleep, should have mentioned. Yes.
And what are the types of hyperthyroidism, you know?
So
Types of
primary,
hyperthyroidism.
yes, sir. Primary hyperthyroidism, secondary hyperthyroidism. In case of primary hyperthyroidism, where T3 and T4 will be raised and TSH will be on lower side, sir. In case of secondary hyperthyroidism, uh, even primary hyperthyroidism is mainly because of the hypersecretion from the thyroid gland, sir. And secondary will be because of the any pituitary adenomas which will be secreting more of thyroid releasing hormone, which will be in turn releasing more of thyroid stimulating hormone, then will be secreting more thyroid hormones.
Which system is more commonly involved in primary?
Sir, CNS will be
Which
involved in.
system is more commonly involved in secondary and why?
Sir, primary central nervous system will be involved, sir. Secondary cardiovascular system will be involved.
Reason?
Sorry, sir, I don't know, sir.
What is the difference between thyrotoxicosis and hyperthyroidism?
Sir, hyperthyroidism is mainly when it is because of the thyroid glands. Thyrotoxicosis is excess of T3 or excess of thyroid hormones, which may not be because of thyroid glands.
Okay.
Okay. Dr. Ramchandran, apart from the pressure effect, you said like the sleep was disturbed in this patient.
Yes, sir.
Why the patient with thyroid disease have sleep disturbances? Whether it is only in hyperthyroidism or hypothyroidism, and what is the cause for it?
Sir, in case of hyperthyroidism, because of the anxiety and because of raised basal metabolic rate, the patient.
So due to basal metabolic rate, sleep will get disturbed.
No, so because of the anxiety and
It is nervousness or irritability,
yes,
and
sir,
muscle weakness and constant feeling of tiredness and malaise that leads to disturbed sleep at night. And why in hypothyroid patients?
hypothyroid patients, there'll be increased sleepiness. Lethargy will be one of the complaint of the patient or symptom.
Lethargy is a complaint in the daytime, na? When the patient is sleeping, why they have disturbed sleep. They may sleep more in some patients. Hypersomnia may be there, but in some patients, there's disturbed sleep. Why in those patients? It is their intolerability to cold at night and muscle and the joint pains.
Yes, sir. Yes.
So both the hyperthyroidism and hypothyroid patients can have a disturbed sleep.
Yes, sir.
Though there is hypersomnia found in hypothyroid patients. Hypersomnia is also found. Right.
General physical examination. An elderly female who is well-nourished and moderately built, conscious, cooperative, and well-oriented to time-place person. Her pulse rate is 80 beats per minute, regular in rhythm, and good volume. Her blood pressure is 180 by 80 millimeters of mercury, measured in right arm in sitting position. And her respiratory rate is 16 cycles per minute and regular. She maintains her saturation at the room air. There is no pallor icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There is no stridor is noticed in supine position. Here are the clinical pictures. On inspection, patient is examined in well-lit room with adequate exposure and due consent. Swelling measuring about 10 cross 10 centimeter noted in front of the neck, which moves with deglutition, and inferior border could not be made out. Extending superiorly up to the thyroid cartilage, and inferior extension could not be made out. Right side up to the anterior border of the right sternocleidomastoid, and left side 2 centimeter lateral to the left sternocleidomastoid. Surface appears to be bossulated, and skin over the swelling is normal. There are no other swellings noted in the neck. On palpation, a swelling of size 10 cross 10 centimeter noted in front of the neck, which moves with deglutition, and inferior border is not palpable. Extending superiorly up to thyroid cartilage, and inferior extension could not be made out. Right side up to the anterior border and of the right sternocleidomastoid, and on the left side 2 centimeter lateral to the left sternocleidomastoid. Surface is bossulated, firm in consistency. Skin over the swelling is normal. Right carotid pulse is palpable in normal position. Left carotid pulse is displaced posteriorly. There is no cervical lymphadenopathy. Tracheal position could not be assessed. On percussion, dull note on direct percussion over manubrium sterni, resonant note heard over parasternal area. Auscultation. Bruit heard over the upper part of the left lobe. A gush of air heard over right side of the midline. systemic examination. The S1, S2 heard in cardiovascular system, and there were no murmurs. Bilateral normovascular breath sounds heard in respiratory system, and abdomen is soft, non-tender, with bowel sounds heard. Higher mental functions are normal. To summarize my case, an elderly female, a known diabetic and asthmatic, presented with complaints of swelling in front of the neck since 10 years, which rapidly progressed over the past 2 years to attain the size of about 5 times the initial size of about 2 cross 2 centimeter, with complaints of hoarseness of voice, discomfort while swallowing, and choking sensation on lying down in supine position since 6 months. On examination, a swelling of size 10 cross 10 centimeter noted in front of the neck, which moves with deglutition, and inferior border is not palpable. Extending superiorly up to the thyroid cartilage, and inferior extension could not be made out. Right side up to anterior border of the right sternocleidomastoid, and on left side 2 centimeter lateral to the left sternocleidomastoid. Surface is bossulated, foaming consistency. Skin over the swelling is normal. Dull note on direct percussion over manubrium sternum. Bruit heard over the upper part of left lobe, and gush of air heard over the right lobe, right side of the neck. So I'm thinking my provisional diagnosis as multinodular goiter with retrosternal extension in clinical euthyroid state.
Yeah, Dr. Ramachandran, can you go to the previous slides?
Yes.
Pulse rate examination, yeah. General physical examination. Okay. What is the importance of a pulse examination in a thyroid patient?
So in case of hyperthyroidism, the pulse rate will be increased. There will be
How much usually the pulse rate is there?
So usually around 110 to 120s.
Around 100, so more than 100.
There's a grading. Actually, there's a grading. It's called price grading of pulse,
Yeah.
right?
So in which situation condition you like to measure the pulse rate? During the daytime or any specific time?
When patient is in when patient is in sleeping, then we should measure the resting pulse rate when the patient is sleeping.
And that's why.
The sympathetic activity of the patient will be minimal during that when patient is sleeping.
Sympathetic activity.
So how do you take a sleeping pulse? Sorry.
It's done by in the hyperthyroid patients, no? There's sympathetic stimulation is already there. So it is basically to differentiate between thyrogenic and neurogenic tachycardia, right? Because the daytime pulse may be simply due to anxiety and all these factors. The patient may not be a case of hyperthyroidism.
Yes, sir.
So if the sleeping pulse rate is more than 80, right? Then you consider it to be there's tachycardia due to excessive thyroid production. And what happens in the hypothyroid patients?
There will be
pulse rate, yeah.
Pulse rate will be on the lower side, sir. It will
Lower
be
side. 10 to 20 beats per minute lower than that.
Yes,
and
sir.
regarding the rhythm?
Regular rhythm
Is found in hyperthyroid patients?
Sir, we'll be finding collapsible pulse in case of hyperthyroidism.
Okay. And regarding the rhythm?
Rhythm will be regular rhythms.
No.
It will be tachycardia, but with regular rhythm.
There are fibrillations also, no? Atrial fibrillation is there. So the pulse rate may be irregular also.
Yes, sir.
So pulse examination is important part in a case of thyroid swelling.
Yes.
Right? Okay.
Okay. How do you take a sleeping pulse rate? You touch the patient, he'll wake up. So how do you take it?
We would if the patient is in the hospital, then we can only go and examine. So otherwise, we can train the patient attenders to examine for the pulse rate and let us know.
You train the patient.
You use a pulse oximeter.
You train
Just
the
put it on the
patient
finger. Or previously they used to use phenobarb and then do the thing. Nowadays, you just have a pulse oximeter. Just put it there.
Yes.
Okay.
Yes.
Okay. Let's go to your next slide.
Yes.
Go on, continue. You said something about gushing of air somewhere. What is that? What is this gushing of air? Gush
Sir,
of air heard over right side of midline. What do you mean by that?
sir, I was suspecting tracheal deviation to the right side, sir. So when I was ausculting, I was hearing gush of air, which was
So just say trachea shifted to one side because of by auscultatory method.
Yeah.
yes,
Right. Gush of air. It sounds as something's coming out from the trachea.
yes.
And you said the patient is having swallowing dysphagia, is it?
Yes, sir. Patient complains of discomfort while swallowing, sir.
No, what discomfort by swallowing? Is there any difficulty in swallowing?
She feels
I mean, can you explain it as a surgeon? As a surgeon, can you explain this discomfort on swallowing? You've mentioned it, so there must be some importance to it. How is it going to affect your diagnosis or your management?
it's a compressive effect of huge goiter, which will be compressing the esophagus, can cause.
You think even a larger goiter can compress the esophagus? Esophagus can only be infiltrated, so it's a sign of malignancy, right?
Yes.
Trachea, fine, can have some issues, right?
Yes.
But esophagus, no, not in a benign condition. Trachea is a huge is a strong structure which is going to prevent the esophagus hides behind it.
Yes.
Okay, let's go back to your. Inferior extension could not be made out. So what does that mean? On
So
deglutition, can you see the inferior border?
Sir, patient on deglutition, the swelling was mobile on deglutition, sir, but moves with deglutition, sir. But inferior border, I could not make up on inspection, sir.
On palpation?
On palpation also, I couldn't palpate for the inferior borders.
So is the Pemberton's positive?
Yes, sir. Pemberton's is positive in it.
Let's have you mentioned that because I probably missed it. So what do you think? Why is this happening?
Sir, there is a retrosternal extension of the thyroid gland because of which I could not palpate for the inferior
Okay,
border.
what's the plunging goiter then? What's the plunging goiter?
Plunging
You've got
goiter is,
retrosternal extension. What is a
yes,
plunging goiter?
plunging goiter is when the patient deglutes, inferior border can be made out, and after deglutition, the swelling moves back to the behind the sternum, sir.
Is that so?
Ramchandra, what are the types of retrosternal goiters and how you clinically differentiate?
Yeah, you got a question now.
Sir, or retrosternal goiter can be because of one which the thyroid gland, primary thyroid gland, the thyroid gland in the neck.
Types of retrosternal goiter.
Mediastinal goiter, so one which can
Not mediastinal, intrathoracic.
Intrathoracic.
What are the other two commonest type?
Plunging goiter and retrosternal goiter extending below behind the sternum.
I will assess clinically.
Clinically, if we percuss on the if we are percussing over the manubrium sterni, we'll be hearing for the dull notes. Then we will be thinking of retrosternal extension of the goiters.
What is plunging goiter then? Okay.
On deglutition, plunging granula, the swelling comes up, comes upside the sternum. So, and on completion of deglutition, it goes back again into the thoracic cavities.
Okay, proceed.
What is rule of one, Dr.
Sorry.
for retrosternal goiter?
Sir?
What is rule of one for retrosternal goiter?
Sorry, sir. I don't know about rule of ones. Sorry, sir. I'll read about it.
1% of goiter is retrosternal. 1% retrosternal goiter may become malignant, and in 1% case, you may require sternotomy for retrosternal goiter.
Yes.
Actually, just like to correct you. Plunging goiter is that the goiter is usually in the retrosternal region.
Yes.
On Volsuvas or on coughing, it comes out and
Yes.
then goes back again. Right?
Yes.
Okay. You said trachea position cannot be there. Then you're saying position cannot be assessed, and now then you're saying there's gushing of air.
Sir, on palpation,
And
I
the trachea is
couldn't
pushed.
palpate for the tracheal ring, sir. But on auscultation, I could hear gush of air on the right side.
Comment on that. You can't comment. Just ignore it.
Yes.
Right.
Dr. Ramchand, what is this relation to the sternocleidomastoid? Relation of this swelling to the sternocleidomastoid.
Swelling is posterior to the sternocleidomastoid, sir. It's deep to the sternocleidomastoid.
Is it always deep to the sternocleidomastoid? Yeah, you can blindly say. Okay,
Yes,
even
sir.
if you're not done, you can blindly say it is deep to the sternocleidomastoid. You know?
Yes.
Because the thyroid swelling can never come in front of the sternocleidomastoid.
Yes.
Then you were telling about the upper border of the swelling up to the thyroid cartilage. You know, thyroid cartilage is the biggest cartilage in the neck. Out of the 9 cartilages which are there, this is the biggest cartilage, and it has got a vertical length of about 2 to 3 centimeters. So you have to tell which border of that, upper border or lower border. So always mention about that. And then you are percussing around the parasternal area. Why you are percussing around the parasternal area? The reason for that?
So, if the goiter was whether if the goiter was so huge that when the parasternal areas were dull on percussion, then I would think the goiter is very large, so which involves which covers even the parasternal area. So I was thinking like that. And
do you think the percussion over the mandibular sterni will be resonant on percussion?
dull?
It will be dull on percussion. No? One way you are saying it is dull, it is resonant on percussion. Just go to that percussion part.
Yes.
Okay, it is dull. Okay. Okay, that's fine. Yeah, it's okay.
Yes.
Yeah. What is this CVS HMF or whatever you written? What is this CNS HMF?
Sorry, sir. Higher mental functions are normals.
Huh?
Higher mental functions are normals.
Don't
Please.
use these abbreviations,
Oh,
like your own
abbreviations
abbreviations.
which are not acceptable.
Yeah, not standard abbreviation in the textbook. You should not use them.
Sorry. Yes.
Okay. How do you manage this patient now? What do you do?
Sir, initially I would like to get ultrasonography of the neck, sir. Then thyroid function, thyroid profile of the patient, and then proceed after the
Okay. You have the ultrasound report, no?
ultrasonography. No, sir. Report I have not mentioned, sir.
Patient has not been worked up yet?
Yes, the patient is worked up, sir. Ultrasonography I have not.
So you are showing the X-rays and FNAC also. So you must have done the ultrasound also, I think.
Yes, sir. Ultrasound is done, sir. Ultrasonography.
Okay, do you remove the ultrasound? What are you looking for in ultrasound? Let's come to that now.
Yeah, that is.
Sir, I would look for the composition of the swelling, sir. Composition of the swelling, echogenicity.
Composition. No, composition is not the right word. What do you mean by composition of the swelling?
So whether it is solid, cystic, or mixed types, based on
consistency, है ना? Eco texture, है ना? Cystic, solid or something, right? It is
Yes.
not composition is not the appropriate word for that. First, you will confirm whether it is a origin of the swelling, that is rising from the thyroid or is something else. First
Yes.
thing that is confirmed on the ultrasound. Then,
Yes. Then I would look for the ecogenic ecogenic foci, and whether the swelling is taller than wider or wider than taller. Then I would look for the margins.
so what inference it will give you? Swelling is taller than wider and wider than taller.
If the swelling is wider than taller, then it is of benign, sir. And if it is taller than wider, then it goes towards malignant condition.
Is it
And to
so?
look for any microcalcifications, and to look for vascularity of the gland, and to look any cervical lymph nodes, and to look for the keratids.
Tell the vascularity. What is the inference? Whatever finding you're describing, please tell the inference from that finding.
Sir, if we are seeing microcalcifications, then it
No,
is.
you said vascularity, like.
Sir, whether the gland is highly vascular or
So in which diseases you get a highly vascular gland?
in case of toxic nodular goiter, we'll be getting, and in case of Graves' disease, we'll be getting
Thyroiditis, basically, na? Hyperthyroidism cases. And
Yes, sir.
thyroiditis, you may get a
Thyroiditis will be
vascular,
getting highly
gland.
vascular. Yes.
Okay.
Okay, Dr. Ramchandra, you said about vascularity. What is restive index? Do you have an idea what is restive index?
Restive index. Sorry, sir, I don't know. I'll study about it.
It is the flow rate during systole and during diastole. That's if you have. So if it's more than 0.7, then
Yes.
chance of malignancy is high. Okay.
Yes.
So that's called restive index.
Restive
Yeah,
index.
go on, please.
How do the ultrasoundists describe the ultrasound report? What do they finally say?
Sir, they'll be describing based on the thyroids, whether it is thyroids 1, 2, 3, 4, 5. Based on that, they'll give us the report, sir.
Does the
So
thyroids
suppose it was
or
sorry.
not?
Sir?
Does the thyroids include the vascularity or not?
No, sir. Thyroids doesn't include the vascularities.
Good.
So suppose it's thyroids 1 or 2, then what do you do?
We'll follow up. We'll ask the patient. We'll think of a benign disease, and we'll ask the patient to follow up, sir. Will not be
Any role of FNAC there?
No, sir. No role of FNAC, sir.
Right. So at what thyroids do you do an FNAC?
So thyroids 3 will be planning for FNAC, sir.
Right. And it's 4 and 5?
Yes, sir. We'll be planning for FNAC, sir.
Okay. Yeah. So go on.
What is the quadruple testing in case of thyroid?
Sir, clinical test, based on the clinical examination, then based on the imaging, that is ultrasonography, and based on the biochemical, that is thyroid function test, and FNAC. These 4 will form the quadruple testings.
Quadruple testing, just like in the breast, we have the triple one.
Yes, sir.
The first in the thyroid is the clinical. Second
Yes,
is the thyroid function test.
Yes, sir.
Third is
Then,
the, and fourth is the histopathology or whatever you want. Yeah.
Okay.
So that is the way. But some people, they include also the genetic markers. They say no, thyroid function has to be done. So you can add to that the genetic markers. But usually the quadruple testing is the clinical, thyroid function test, imaging, and then the cytology or histology.
Yes.
Okay.
Okay, so you have this follicular neoplasm,
Yes, sir.
Bethesda grade 4. What do you mean by this? How
So
do you interpret this now?
Bethesda category 4 will be suspicious of malignancy, sir.
And Bethesda 3 or follicular will you not suspect of malignancy?
Bethesda 4 is suspicious of malignancy, sir. Bethesda 3 is just follicular, sir. And Bethesda 2 is benign, sir. Bethesda 1 is
So what is the difference between 3 and 4? You've got category 4. Suppose it was 3. What is the difference between the two?
sir, if it is 3, then we'll be thinking more of a follicular adenoma, sir. If it is category 4, then we'll be thinking of
You might
follicular.
be thinking of anything. You might be thinking of anything. Well, how does it affect your management?
Sir, 3 goes more towards of adenoma, sir. Or 4 goes towards follicular
Okay,
cancer.
let me put it this way. What are the chances of malignancy in 3 and 4? Follicular 3, Bethesda 3, follicular Bethesda 4. In
5 to
in
15, 3, 5 to 50,
yeah, go on.
5% to 50% in 15.
It is 30% in 3 and 66% in 4,
Yes, sir.
right? So you
Yes.
can't take a chance.
Yes.
So it's not follicular, even if majority may be follicular adenoma,
Yes, sir.
right? But there's a 33% chance of malignancy in 3, right? One
Yes.
third of them will turn malignant. Okay, so that affects your management.
Yes.
Okay, so now how do you go about?
Sir, I'll plan
What was the size of the lump in this? What was the size of the lump
sir, 10 cross
on
10.
ultrasound? Huh?
Sir, around 10 cross 10 centimeters.
Okay, so how does this now let's come to what are the guidelines for management now? What is ages, AMEs, or whatever, all those kind of things which you've heard of?
Yes, sir. Ages, ME's criteria. Ages will be taking the age of the patient and grade of the grade of the grade of the disease, and then extra thyroidal extension, and S is
S is
size
size.
of the tumors.
So here now it's Bethesda 4 with more than 4 centimeters.
Yes, sir.
So what's the treatment for this now?
We're planning for total thyroidectomy, sir.
And suppose it was papillary, then what is the cutoff size in follicular and what is the cutoff size in papillary?
4 centimeter in case of follicular, sir, and
Very
even
good.
in papillary,
In papillary?
3 centimeters in case of papillary.
No, 1 centimeter.
Yes, less than 1
Right.
centimeter is a micropapillary, and more than
Yeah.
Yes, sir.
Yeah.
Yes.
Right. Okay. Sir, please. Anyone? Okay. Okay. No one asking.
Yeah.
Now what do you do? You've got to see. What do you do now? You've got this FNAC which is Bethesda 4 follicular.
Sir. We'll be planning for the total thyroidectomy, sir, and then before going for we'll get a CT of the neck and chest of the patient, sir. Then based on that,
Do
we'll
the X-ray of the neck of this patient.
yes, sir.
Yeah, read that. What do you find?
This is a AP view of the X-ray of the patient, where we can see a soft tissue in front of the neck, which is extending from behind retroclavicular area, and on the lateral neck X-ray, we can see the compression over the trachea with normal epiglottis, and tracheal deviation can be made out in the
How can you say normal epiglottis here? Where you see the epiglottis? X-ray may you can see the epiglottis.
No, sir. No, sir. No, sir.
What is important in the X-ray here? Why do you have to take an X-ray in a case of thyroid?
Sir, to
Swelling.
look for the tracheal deviation and compression of the tracheas.
To show in
And
the
Calcification.
trachea is
any microcalcifications can also be picked.
where is the trachea compressed on the lateral view? Can you show that?
I don't know whether my cursor.
Yeah.
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 Yes.
Yeah, right.
Yes.
That's right. Yeah.
Yes.
So how do you say it is compressed?
Sir, there is narrowing of the shadow, sir. When we compare to superior upper part, then as we are tracing it below, then we can see the pressure effect of the swelling over the trachea, sir.
What is this kind of trachea called?
Scabbard.
Scabbard.
Yes.
What is scabbard? What do you understand by that?
Sword of sword. So anterior posteriorly compressed trachea looks like a sword, sir. That's called scabbard trachea. Yes.
Compressed from all sides.
It's not the sword, dear. It's not the sword. Mia, the thing where you keep the sword.
Yes, sir. The cover of the sword. Yes, sir.
Yeah.
So why did you have this X-ray? What was the purpose of having this X-ray?
So to look for retrosternal extension, tracheal compression, and if we are planning for the intubation introp, then tracheal compression can we can be getting to know it, sir, and tracheal deviation can be seen.
So what are the other things the anesthetist may need in this patient to pass the tube?
We can plan for fiber optic intubation, sir, or awake intubation, or even while intubating.
Anything simpler, fiber optic, all that is fine. Anything simpler.
Sir, while intubating, we can lift we can pull the.
Have you seen these people intubating? They use something inside. They use
video laryngoscopy can be used.
They use a bougie.
Yes, sir. Bougie can. Yes.
And what is the importance of for you in the compressed trachea as a surgeon?
While intubating, we can.
Intubation is the job of the anesthetist.
Yes, sir. We will be thinking of softening of the tracheomalacia can be kept in mind before while operating.
So what will happen?
Sir, post operation, then trachea might collapse, sir. So we should have and patient might go breathless. So we should keep in mind about the tracheomalacia or tracheal compressions.
You have to counsel your patient that this patient will
require
tracheostomy, no?
Yes, sir.
Okay. Suppose there's tracheomalacia. What is the treatment for it?
Sir,
how will you manage this patient?
Introp, as soon as we excise the thyroid gland, we'll ask the anesthetist to pull the ET tube and look for the compressibility of the trachea and pull and again
Why do you ask it just after removal of after removal of the after surgery? You can see whether if they extubate and then they can re-intubate. Then what do you do? Suppose the patient is having tracheomalacia. Then what do you do?
Sir, keep the ET tube in place for 24 hours. Elective
Why
intubation.
24 hours? Why 24 hours? Why not 48 hours? Why not 72 hours? You think 24 hours is sufficient? And you think that the cartilage will recover in 24 hours?
Sir, edema might reduce, sir. Edema will be reducing in 24 hours.
So usually 48 hours and all, after that, some sort of fibrosis happens.
Yes.
Some sort of inflammation. They keep the trachea open. So around 48 hours, 2 to 3 days, got to keep him intubated.
Yes.
Right.
Dr. Ramchandra,
sir,
can the lower border of goiter can extend above the manubrium sternum rather than going retrosternally?
Sir,
is it possible?
Intrathoracic pressure, negative intrathoracic pressure usually pulls inside the thoracic cavity. And deep cervical fascia is not attached inferiorly, sir. So there is a possibility, sir.
In which condition it may extend above the manubrium sternum?
In case of any congenital anomalies, sorry, sir, I don't know, sir. Sorry, sir.
Infiltration of deep cervical fascia by malignant thyroid.
Yes,
In that condition, it may extend above the manubrium sternum rather than going retrosternally.
yes.
Dr. Ramachandran, you said one thing that on ultrasound, if width is more, it is towards the malignancy of the thyroid gland.
Yes, sir.
Huh? If the length is
more taller, then it goes towards the malignancy, sir.
Is it so, sir? May I have the comment from the senior examiners, Khanna sir, Sahai sir?
Sorry,
Hello.
sir, I missed that. Yeah. What did he say?
So he said that if the thyroid gland size is more tall, then it goes towards malignancy. If it is more wide, it goes towards benign.
Yeah, taller in ultrasound for the cells, for the lump, like in breast.
It is for the lump, yeah. Not for the thyroid gland as a whole.
Just for the breast, actually. Taller than wider.
Yeah, that's
right?
what he said that statement because and Dr. Ramachandran on the ultrasound examination of the lymph node.
Yes, sir.
What are the signs of ultrasound that it is being infiltrated by the malignant cells?
Sir,
Those are more specific signs and important if you get a cervical lymph nodes along with the thyroid gland. What are those signs?
Sir, if there is a loss of fatty alum and there is cortical thickening and round in shape and
Round in shape, yes.
yes, sir. These points go towards
Round in shape, hypoechogenicity, loss of echogenicity at hilum, and
increased
short
cortical
axis long axis ratio more than 0.5. Then it is suspicious of malignancy.
Yes.
Right?
Yes, sir.
And regarding that lesion, I'm not sure. So you please read it. I will also read in the literature on a thyroid lesion.
Yes.
Okay. What are the complications you are going to encounter? Sir? Sir? Hello.
Sir? Sir? I couldn't get. Hello? Hello?
Hello.
Yes, sir.
But you said procedure you're
Taller
going
than
for
white. Dr. Hemant, taller than white is more likely to be malignancy.
Malignancy.
Yeah.
Okay.
Yeah, Hemant sir.
Yeah.
Yeah, Gurushantapa here.
Yeah.
Yeah, sir, these sections are taken patient being in supine. And when we put a probe, the height is taken from anterior-posterior direction.
Yeah.
In supine position. So if that is how the lobe, it is pertaining to
From the
that
skin
nodule,
surface, from the skin margin.
Yeah, pertaining to the nodule in relation with the remaining gland. So in the anterior-posterior direction towards the skin. So if that height is more than the breadth, then likely to be a malignant nodule. It is pertaining to the nodule, not the gland.
Not the gland, yes, sir. Because he said
sir, it is not the gland.
Yeah.
It is a nodule, sir. Nodule. We are
It is the
describing
nodule,
that nodule. Nodule,
yeah.
sir. Nodule in relation with the remaining gland.
Yeah. Thank you. Thank you.
Yes, sir. Thank you, sir.
So should I play the CT video, sir?
Okay. Yeah, let's have the CT then.
Yes.
So the trachea is definitely shifted to one side.
Yes.
The left.
The trachea shifted towards the right side, sir. And
Yes.
And the left lobe is mainly enlarged than the right lobe, sir.
Yeah. Okay, Dr. Ramchandra, what's the difference between total thyroidectomy and near total thyroidectomy? What are the indications? When do you do them?
Sir, total thyroidectomy will be all both the lobes and isthmus, entire thyroid gland is removed, sir. And here total only one side, about 8 grams of the gland is left behind, and entire rest of the gland is excised, sir.
How do you measure 8 grams
How do
during
you-
the surgery?
How do you measure 8 grams?
Sir, around the parathyroid will be leaving
No,
a small amount of
no.
tissue that
It is
might.
a
Yeah,
tissue
leave
left
some
in the
around the pathos.
tracheoesophageal groove.
Yes, sir.
Yeah, some
Right?
sliver around the tracheoesophageal.
Yeah, so that is roughly equal to 8 grams. So you don't measure it basically, you leave it there, right?
Right. So what's the danger for, why don't you do a near total in this? Why do you want it, it's a benign, suppose it was just multinodular goiter, Bethesda 2 or 3.
Sir, we are thinking of malignancy. There will be a chances of malignancy as Bethesda category 4. So we are
No,
planning.
I'm
No,
talking,
so
I'm
are you
giving,
saying
suppose it
benign
was
goiter?
benign,
What you will prefer?
benign
Subtotal?
multinodular goiter.
Yeah, what subtotal or total thyroidectomy?
There will be chance of recurrence of the goiter again, sir. So and it's a long-standing goiter which might have a malignant transformation. So we'll be planning for total thyroidectomy.
Actually, wait, that's right. Managing hypothyroidism is
Yes.
easy. Diagnosing hypothyroidism is very difficult. Right?
Yes.
Managing hyperthyroidism is very difficult. Diagnosing hyperthyroidism is very easy. Do you get me? So we prefer that the patient is hypothyroid rather than hyperthyroid postoperatively.
Yeah.
Now, postoperative, what do you do about it? You remove the whole thyroid gland. What do you do now? How do you replace how much?
Sir, we'll initially wait for the histopathological report, sir. And then
Okay.
based on the histopathological report, we'll plan for the further management.
What? Okay. Suppose the histopath is the same as follicular neoplasm,
Means follicular
not otherwise.
follicular cancer, sir. So in case of if it's follicular adenoma, we'll just plan for the replacement of the thyroxine, sir. And if it
How much?
initially we'll start with 100 micrograms of thyroxine, sir. Then based on that again we'll titrate according to the thyroid function report, sir.
Okay. So what are the complications of total thyroidectomy?
Sir, immediate complications like hemorrhage, reactionary hemorrhage can be one of the complications, sir. Then hypocalcemia can be another complication. Then recurrent injury to the recurrent laryngeal nerve, injury to the recurrent laryngeal or hoarseness of voice and stridor can be these are all can be the complications of the total thyroidectomy.
Dr. Ramchandra, what is the difference between primary, reactionary, and secondary hemorrhage?
Primary hemorrhage is on table. If the patient have bleeding, then we'll be saying primary hemorrhage. Reactionary hemorrhage is because of primary can be because of slip, primary on table bleeding. So secondary reactionary hemorrhage is within 24 hours of the operation, mainly because of slippage of the knots. And secondary is in 3 to 10 days of the durations.
Usually it is after 10 days, secondary.
Yes, sir.
Not between, it is because of infection.
Yes, sir.
Secondary hemorrhage is because of infection and it usually occurs after 10 days.
Yes.
And reactionary hemorrhage is usually 24 to 72 hours. And primary is on table.
Yes.
What are the various types of thyroidectomies in current era?
Sir, total thyroidectomy, sir. Then near total thyroidectomy and hemithyroidectomy.
So nowadays we do not use the subtotal thyroidectomy.
Yes.
Subtotal thyroidectomy was used before when the concept of the total thyroidectomy came. So near total is done only to preserve the parathyroids and the recurrent laryngeal.
Yes,
if you are not an expert surgeon to carry out the thyroid surgery and you want to save that, then you go for the near total. Or you can do the total lobectomy on one side and near on the opposite side, what is called Huntley technique, which is there. Right? Or you can do a hemithyroidectomy. What do you understand by hemithyroidectomy classically? What is the meaning of that?
Lobe and isthmus, lobectomy plus hysterectomy will form the hemithyroidectomy.
The classical hemithyroidectomy, which is there, is that you remove the lobe,
Yes.
you remove the isthmus, and also you remove a very small crescent of the opposite lobe. Okay, usually people do not do that, but that is the classical hemithyroidectomy which is there. That you remove a small crescent of the opposite lobe also.
Yes.
How do you know at operation that this is the parathyroid gland or not?
So if it sinks in the if it sinks in the normal saline, then it is parathyroid, sir. If the fat floats, sir.
When you removed that, na?
Yes, sir.
But when it is intact, then how will you know it is parathyroid?
It's slightly brownish in color, sir. So based on that, golden brownish in colors.
It is angry looking, na? There are small blood vessels which are running over that. Can you give some dye to the patient to know that whether it is the parathyroid gland or not?
Methylene blue can be given for the to visualize or the glands.
Blue can be given or indocyanin green can be given for the patient to see for the parathyroid. And the test which you are telling us that if the fat is there, it floats.
Yes, sir.
But a normal parathyroid will not sink down.
Yes.
It will in between there. But if it is parathyroid adenoma is there, then that will sink down there.
Yes.
When do you see for the deficiency of the parathyroid? After how many days of the operation?
After third day, we'll be seeing for the deficiency. After 3 days, we'll be looking for examining for the parathyroid deficiencies.
What is the first sign?
Perioral numbness is the first sign.
So what should be reaction? If the perioral numbness is there, what you should do?
So we'll be giving in calcium gluconate and calcium gluconate.
You want to send the blood for the calcium or not?
Initially we'll look for the calcium levels. So based on that, we'll give a calcium gluconate.
When you are taking the blood for the calcium, what precaution you will take?
You should not squeeze the muscles, sir.
You should not use the tourniquet.
Tourniquet should not be used. Yes.
Should not be used. Yes. So you should send the blood sample. Apart from the calcium, do you want to send anything else?
Magnesium levels can also, magnesium also will be sending.
Any other blood parameter which can change the absolute value?
Albumin will change the absolute value. Yes.
But yes, right. Okay. Right. Dr. Kanegaval, can we close now?
Yes. Maybe we should allow him to ask any doubts to be clarified, sir, and Gurushantapa sir can give his final word and then we'll call a close, sir. Ramchandra, do you have any questions to ask or doubts to be clarified?
No, thank you, sir. Happy this
Gurushantapa sir, are you with us, sir?
Yes, sir. Yes, sir. Yes, sir.
Sir,
I'm with
would
sir.
you like to add any comments, sir, before we call a close?
Nothing, sir. Nothing. It was a good discussion. Only thing, the students should have a little boldness to answer the questions. Doing some silly mistakes probably may not be much acceptable. Like one of the question was why thyroid cannot extend over the manubrium sterni. Why always it is inside. So they should be in a position to answer nicely. Otherwise, sir, even I could make out some 2-3 points from the examiners. Thank you, sir, for the opportunity.
Thank you, sir. Thank you, Ramchandra. Thank you, all the faculty. Thank you for joining us this evening. Sorry, we have to delay the process because the first case took longer. Apologies for that. And then we will meet coming Friday with the different case for discussion. Kanna sir, can we call a close, sir?
Yeah, please.
Thank you, sir. Good
Thank
night,
you so
sir.
much.
Good night,
Thank
sir.
you, sir.
Good night, everyone.
Good night.
Thank
Good
you.
night,
Thank
sir. Good night, sir.
Thank you, sir. Thank you,
you.
everyone.
Good night.
Ramchandra.